Right, beta. A very good afternoon to all of you, and I hope you are able to revise the vascular surgery. Just give me a moment. Let me just attach the mic. Right, beta. Now let us just focus on the endocrine surgery. Just a small correction in the answers of vascular surgery. The question number 4, the correct answer is B. So just make a small correction there. Question number 4 in vascular surgery, the answer is B. Right, beta. Now let's talk something about endocrine surgery. Herein we talk about thyroid and breast. Now, beta, thyroid is a topic which is actually an overlapping topic between so many subjects. We read about thyroid in anatomy, we read about thyroid in physiology, biochemistry, pathology, pharmacology, not much in microbiology, forensic medicine, PSM, ENT, even ophthalmology, medicine, even in obs and gynae, right? What we'll be doing is we'll be restricting ourselves to the discussion of surgical aspects of this thyroid gland. Right, beta. So focusing on the surgical aspects of thyroid gland. Now, in surgery, we focus mainly on goiter. And what is goiter? Goiter, beta, is simply enlargement of the thyroid gland. Now, this what you're seeing here, can you see some enlargement in the thyroid gland here? And here also, if you carefully take a look, you can see that yes, there is some enlargement of the thyroid gland, right? So this is what we call as goiter. Now, beta, if we just try to understand why this thyroid gland is enlarging, why there is enlargement of this thyroid gland. For this, if we try to analyze the basic physiology of the thyroid gland, how this thyroid hormones are formed actually. First, let us try to understand the T3 and T4. They are synthesized by the follicles inside the thyroid gland. We all know, beta, that God has given this thyroid gland in the lower part of the neck. There are two lobes of this thyroid gland which are joined with each other by isthmus. They are having numerous follicles inside, that is the follicular cells. They are also having parafollicular C cells inside. The main job of this thyroid gland or the thyroid follicles is to produce the thyroid hormones T3 and T4. How this T3, T4 is formed? Iodine and tyrosine. These are the two people. Whatever iodine we take in diet, that iodine is trapped by the follicles and then it is oxidized to iodine. Iodine then binds with tyrosine to form monoiodotyrosine, and then there is coupling of mono plus mono to form di, di plus mono tri, and di plus di tetraiodotyrosine. My dear friends, if we just try to understand that there are 4 stages in the synthesis of thyroid hormones, they are remembered by the mnemonic TOBC. T for trapping, O for oxidation, B for binding, and C for coupling. That means whatever iodide is taken from the diet, that is first trapped by these follicles, oxidized to iodine. Iodine binds with tyrosine to form monoiodotyrosine, and then there is coupling of mono plus mono to form diiodotyrosine, and then this di plus mono forms tri, and di plus di forms tetra. So that is how T3, T4 is formed inside the thyroid gland. Now, whatever T3, T4 is formed, that binds with the thyroglobulin inside the follicle and forms the complex T3, T4 thyroglobulin complex. Beta G, whenever there is requirement of the thyroid hormones by the body, for example, suppose suddenly, immediately right now you receive a news that the place where you are reading right now, approximately 500 meters from your place, the National Board of Examination has come up with the question paper of 17th of December. So what you are going to do? You are immediately going to run and you would like to fetch that question paper. So you will be needing these thyroid hormones. So whenever there is requirement of thyroid hormones by the body, what happens? This complex inside breaks. T3, T4 comes into the circulation. As soon as T3, T4 comes into the blood, it binds with the plasma proteins albumin, globulin, transthyretin. Majority of T3, T4 in the blood remains bound to the plasma proteins. Very little amount of T3, T4 remains free in the blood, and it is the free T3 which is the biologically active form, which is responsible to carry out the functions of thyroid gland. Now, if suppose the T3, T4 levels are normal in the blood, everything is wonderful. Why goiter happens? Why this thyroid gland enlarges? Most common cause is deficiency of iodine. Iodine is something which we take in diet, and majority of this iodine comes from the salt. Namak se aata hai. We all know, beta, there are two types of salt available in the market. One is a plain salt, another is a iodized salt. Generally, we prefer taking the iodized salt, right? Okay, there are two types of salt available. One is a Tata Namak, another is a Sada Namak, or you can say one is a Patanjali Namak, another is a Sada Namak. If suppose somebody is taking plain salt, that means non-iodized salt. That means there is no iodide coming from the diet, no trapping, no oxidation, no binding, no coupling, no T3, no T4. That means in the blood, T3, T4 levels will fall. Now, beta, if T3, T4 is not getting synthesized and this T3, T4 level, this T3, T4 is not formed, what is happening in the blood? The T3, T4 levels are low. Now this blood is traveling through all parts of the body. You know that this blood is also going to the brain. We can see this, beta. This blood is going towards the brain. Now just imagine that if T3, T4 levels are less, then this blood which is going to the brain, in the brain there is a big boss, hypothalamus. Hypothalamus comes to know that T3, T4 levels are low in the blood. So hypothalamus starts secreting an MCQ, that is TRH. TRH. This is secreted by hypothalamus. This is thyrotropin releasing hormone. And this TRH acts on the anterior pituitary, increases the release of TSH. TSH is thyroid stimulating hormone. Thyroid stimulating hormone. And now what is happening? The levels of TRH and TSH, they are increasing. This TSH now comes on the thyroid, and the job of this TSH now just imagine, beta, if the TRH TSH is high and this TRH and TSH, now this TSH is going to act on the thyroid follicles. The job of the TSH on the thyroid follicles, this TSH promote the release of T3, T4 from the thyroid gland. That means whatever T3, T4 is formed inside the thyroid gland, that will be released into the blood. And there is another action of this TSH on the thyroid follicles. This TSH keeps on irritating the thyroid follicles, which causes enlargement of the thyroid follicles. And if the thyroid follicles enlarges, then all the follicles in the thyroid will enlarge and the entire thyroid gland will enlarge, and this enlargement of the thyroid is what we call as goiter. So a simple thing to understand, beta, very simple to understand here. Let's do it once again. If there is deficiency of iodine, that means T3, T4 is not getting formed in the follicle. T3, T4 in the blood is less. Blood is flowing through the brain. Less T3, T4. Hypothalamus secrete TRH. Acts on anterior pituitary. TSH. TSH acts on the thyroid follicle. Two functions. promote the release of preformed T3, T4 from the follicle into the blood, and enlarge the follicles. So this TSH, whenever it will be high, it will cause enlargement of the follicles, which will lead to goiter. My dear doctors, this particular scenario of iodine deficiency, even if the TSH is high, but if iodine is not there, then T3, T4 is not getting formed inside the follicles. That means TSH, which is also responsible to promote the release of preformed T3 and T4, if iodine is not there, T3, T4 is not there in the follicle, then how this TSH will increase the release of this T3, T4 from follicle into the blood? That means despite a high TSH, but if there is no iodine, there is no T3, T4, so how this T3, T4 will increase in blood? That means TSH will keep on increasing, but despite this T3, T4 is not increasing. This high TSH will keep on increasing the follicles, and if all the follicles in the thyroid enlarges, this is what we call as a diffuse goiter. Diffuse goiter. If suppose we come to know that, oh, this is diffuse enlargement of the thyroid gland, then we can supplement iodine in this patient. As soon as you give iodine in this patient, what will happen? Immediately the follicles which were there in the thyroid, they were hungry, they wanted this iodine, they will immediately take up this iodine, and then these follicles will immediately start forming this T3 and T4. And once the T3, T4 starts forming, then this T3, T4 will come into the blood, T3, T4 levels in the blood will increase, TRH decrease, TSH decrease. If TSH decrease, the follicles will also decrease, and whatever follicles enlarged, now if iodine is supplemented, T3, T4 has started forming, T3, T4 will increase in blood, TRH will decrease, TSH will decrease, and the size of the follicles will also decrease, and this goiter will disappear. That means diffuse stage of goiter is reversible just by supplementation of iodine. Sometimes, if suppose there is no iodine supplementation, and the patient is having diffuse goiter, the follicles are enlarging, because there is no iodine coming, no T3, T4 getting synthesized, T3, T4 low, TRH, TSH high, follicles enlarging. A stage will come when there will be necrosis taking place in some of the follicles. And if necrosis starts in the follicles, then these necrotic follicles will join together to form a nodule. This can be a single nodule, or there can be multiple nodules. This is what we call as a simple nodular goiter and a multinodular goiter. The images, what we are seeing here, these images, what we are seeing here, beta, if you carefully take a look here, can you appreciate there is a nodule here, this nodule? There is another nodule, what you can see here. So actually speaking, it is a case of multinodular goiter. But when we are looking the patient just on inspection, many times we feel there is a single nodule, and we can label this as solitary thyroid nodule. This image has been asked in our exams. This is the image of multinodular goiter. There are multiple nodules in the thyroid gland in both the lobes. Once the nodule has formed, nodule is having the necrotic follicles, and necrotic means dead follicles, right? Now, at this stage of nodular goiter, if you supplement iodine, then T3, T4, whatever follicles are viable, they will start producing T3 and T4. But even supplementation of iodine to these dead follicles, if they are dead, they will not be able to produce this T3 and T4. That means a nodule once formed, it is necrotic, dead. So supplementation of iodine is not going to reverse the nodular stage of goiter. That is why we say, beta, that nodular goiter is irreversible. I repeat this entire story in Hindi, beta. So those who are not able to understand Hindi, just listen for 5 to 6 minutes. I want to re-explain the concept in Hindi once again. हम गोइटर की चर्चा कर रहे हैं बेटा। गोइटर का मतलब क्या है? गोइटर का सीधा सीधा मतलब है कि थायराइड ग्लैंड बड़ा हो गया है। थायराइड के बड़ा होने का सबसे मुख्य कारण है आयोडीन की कमी होना। अगर आयोडीन की कमी होती है तो T3 T4 नहीं बन पाता। अगर T3 T4 नहीं बन पाएगा तो T3 T4 ब्लड में नहीं आ पाएगा। अगर ब्लड के अंदर T3 T4 का लेवल कम होता है तो जब ये खून ब्रेन से निकल रहा होता है वहां पे हाइपोथैलेमस को पता चलता है। हाइपोथैलेमस TRH ज्यादा निकालने लगता है, थायरोट्रोपिन रिलीजिंग हार्मोन, और ये TRH एंटीरियर पिट्यूटरी पे एक्ट करता है जो TSH ज्यादा निकालने लगता है, थायराइड स्टिमुलेटिंग हार्मोन, और ये TSH फिर थायराइड के फॉलिकल्स पे आके अपना काम दिखाता है। और इस TSH के दो काम होते हैं, जो भी T3 T4 फॉलिकल के अंदर बना हुआ है उस T3 T4 को फॉलिकल से बाहर ब्लड में भेजा जाए, और ये TSH फॉलिकल को बड़ा भी करता है। अगर मान लीजिए आयोडीन की कमी है, T3 T4 बन ही नहीं रहा है, यानी कि ब्लड में T3 T4 लगातार कम ही है, तो TRH बढ़ता जाएगा, TSH बढ़ता जाएगा, और TSH के बढ़ने के बावजूद भी T3 T4 नहीं बढ़ रहा है क्योंकि आयोडीन ही नहीं है, तो बन ही नहीं रहा है। इसका मतलब TSH लगातार बढ़ता ही जा रहा है, और इस TSH के बढ़ने से जो फॉलिकल्स हैं वो भी बढ़ते जा रहे हैं। जब सारे के सारे थायराइड के फॉलिकल्स बढ़ जाते हैं तो उसको अपन बोलते हैं डिफ्यूज गोइटर। अगर पेशेंट इस स्टेज पे हमारे पास आ जाए और हम इस पेशेंट को आयोडीन दे दें, टाटा नमक खिला दें, तो जैसे ही ये आयोडाइज नमक अंदर आएगा वैसे ही थायराइड के जो फॉलिकल्स हैं वो इस आयोडाइड को अपने अंदर लेंगे और T3 T4 बनाना शुरू कर देंगे। ब्लड के अंदर T3 T4 की मात्रा बढ़ जाएगी, ब्रेन से TRH और TSH की मात्रा कम हो जाएगी। अगर TSH की मात्रा कम हो जाएगी तो जो फॉलिकल्स बढ़ गए थे वो वापस से रिग्रेस हो जाएंगे और कहानी एकदम नॉर्मल हो जाएगी। यानी कि अगर डिफ्यूज गोइटर वाली स्टेज पे पता चल जाए और आयोडीन दे दिया जाए तो ये डिफ्यूज गोइटर अपने आप गायब हो जाता है और पेशेंट ठीक हो जाता है। किसी सर्जन वगैरह की जरूरत नहीं पड़ती। लेकिन मान लीजिए अगर डिफ्यूज गोइटर भी है और आयोडीन का सप्लीमेंटेशन, आयोडीन हमने नहीं दिया, इसका मतलब ब्लड के अंदर T3 T4 कम ही रहेगा, TRH TSH बढ़ता ही रहेगा। अगर TSH बढ़ता ही रहेगा तो ये फॉलिकल्स भी बढ़ते रहेंगे और एक स्टेज आएगी जब ये फॉलिकल्स बेचारे टूटने लग जाएंगे, और जो टूटे टूटे फॉलिकल्स होते हैं वो आपस में मिलके एक नोड्यूल बना लेते हैं। ध्यान रहे, ये जो नोड्यूल है इसके अंदर डेड फॉलिकल्स होते हैं मेनली। ये नोड्यूल एक सिंगल नोड्यूल भी हो सकता है या मल्टीपल नोड्यूल्स भी हो सकते हैं, जिसको अपन सिंपल नोड्यूलर या मल्टी नोड्यूलर गोइटर का नाम दे सकते हैं। एक बार अगर नोड्यूल बन गया थायराइड के अंदर, उसके बाद अगर हम आयोडीन का सप्लीमेंटेशन करना चाहते हैं तो आयोडीन देने से जो नोड्यूल बन चुका है, जो डेड फॉलिकल्स पड़े हुए हैं जिसके अंदर, आयोडीन देने से वो डेड फॉलिकल्स गायब नहीं हो पाएंगे। यानी कि नोड्यूलर स्टेज गोइटर की इरिवर्सिबल है, आयोडीन देने से वापस नहीं जा पाएगी। That means, as a doctor, in clinical practice, we come across these nodular goiters. Now, if there are multiple nodules, or even if there is a single nodule which is becoming bigger in size, there can be some problems to the patient. This nodule may put compression on the underlying structures, and the underlying structures in this area, the trachea and the esophagus. If these nodules start putting pressure on the trachea, अगर सांस की नली को ये नोड्यूल्स ने दबाना शुरू कर दिया तो पेशेंट को सांस लेने में तकलीफ शुरू हो जाएगी। patient will not be able to breathe if there is compression of trachea by these nodules. Dyspnea, difficulty in breathing. If by chance these nodules are putting pressure on the esophagus, and if the esophagus is getting compressed, patient will not be able to swallow the food nicely. Difficulty in swallowing is dysphagia. So these multinodular goiters can present with dyspnea and dysphagia. Sometimes complications can occur in these nodules. Many times we see that central part is necrotic, but there might be some activity at the periphery of the nodule. And sometimes the activity at the periphery becomes overactive and start producing suddenly more T3 and T4. It becomes autonomous. Rarely, if more T3, T4 is being produced by the active follicles at the periphery of the nodule, then patient may have raised levels of T3, T4 in the blood. That is called as secondary thyrotoxicosis. And sometimes in long-standing goiters, if the goiter is there for long period, cancer can occur in these goiters. Follicular thyroid cancer can occur in long-standing endemic goiters. So these complications can be associated with multinodular goiter. When the patient comes to us with such a huge swelling in the neck, we do the clinical examination, and on clinical examination we can palpate these nodules. We can do an ultrasound of the neck. We'll see multiple nodules in the thyroid gland. We can do a ultrasound guided fine needle aspiration cytology, and that will show us colloid goiter. Now, whether we should do some treatment for this multinodular goiter or not, it depends. If the patient does not have any problems, if there are no complications, and patient is not worried about it, patient does not have any cosmetic issues also, then we can leave it like this. We just keep a follow-up for this patient. But if by chance these nodules are causing dysphagia, dyspnea, or they are associated with complications, secondary thyrotoxicosis or follicular thyroid cancer risk is there, or if the patient is not comfortable with this enlargement in the neck, for cosmetic reasons patient wants to get rid of this, then yes, we can remove this thyroid gland. To destroy this thyroid gland, if we have to use medicine like antithyroid drugs, in nodular goiter, they do not have any role because nodular goiter mainly are having dead follicles. So the medicines cannot act on dead follicles. If we try to destroy this thyroid gland by some radioisotope like radioiodine 131, then also this isotope treatment is not effective because these nodules are dead nodules. They will not be taking up this radioiodine. So the only option left with us in treatment is surgical removal. And in surgical removal, the thing is very simple. If suppose only one lobe of the thyroid is involved, then we just remove one lobe along with the isthmus. But if both the lobes of the thyroid are involved, then we remove both the lobes or we remove the complete thyroid. If you are removing only one lobe with isthmus, that is called as hemithyroidectomy. Hemithyroidectomy. If you are removing both the lobes of the thyroid, that is called as a total thyroidectomy. So that is how we treat these nodular goiters. Let's take a look what is written in the workbook. So in this thyroid gland, goiter simply means enlargement of the thyroid gland. Most common cause is iodine deficiency. Whenever the iodine will be less, the T3, T4 synthesis will be less. The TRH and TSH will be high. TRH is thyrotropin releasing hormone. and TSH is thyroid stimulating hormone. If the TSH is high, then TSH will promote the release of preformed T3 and T4 from the follicle into the blood, and TSH also causes enlargement of the follicle. When all the follicles enlarges, this is called as diffuse goiter, and diffuse stage of goiter is reversible with supplementation of iodine, or we can even give thyroxine if iodine is not available. By giving thyroxine, you are trying to raise the levels of T3, T4, and if T3, T4 increases, then TRH, TSH will decrease, and if TSH decrease, the follicles will regress and the goiter will disappear. Nodular stage of goiter, that is irreversible. There can be either single nodule or there can be multinodular goiter. Since diffuse goiter is reversible, this can be treated without any significant intervention. Nodular goiter is irreversible. Usually the patients are asymptomatic, but sometimes the patient can present with pressure symptoms like dyspnea and dysphagia. Sometimes this nodular goiter can be associated with complications. Complications can be secondary thyrotoxicosis, and follicular thyroid cancer. Secondary thyrotoxicosis and follicular thyroid cancer. How to approach beta? This image what you are seeing, this has been asked in the MCQs. Identify the pathology. This is a case of multinodular goiter beta. In our clinical approach, we do the clinical examination, we can do the ultrasound, we can do ultrasound guided FNAC, that is fine needle aspiration cytology. In the treatment, if the patient is having symptoms, or if there are complications, or for cosmetic reasons, or for patient's wish, we go ahead with the surgical removal. And in surgical removal, what we are doing nowadays, suppose in this particular picture, or rather what I'll do is, there are just two type of stories. If suppose there are nodules involving only one lobe of the thyroid gland, then we are simply removing only one lobe of the thyroid gland along with the isthmus. This is called as hemithyroidectomy. But if there are nodules which are involving both the lobes of the thyroid gland, then we remove the entire thyroid gland, that is a total thyroidectomy. So these are the two options in the surgical treatment what we have nowadays, hemi and total thyroidectomy. Hemithyroidectomy is simply removal of one lobe of the thyroid along with the isthmus, and total thyroidectomy is removal of complete thyroid. Earlier, there were options like subtotal thyroidectomy and near total thyroidectomy. There is one term called as retrosternal goiter. Now retrosternal, that means behind the sternum. So suppose beta I say that this what you are seeing is the neck area, right? And here suppose would be the sternal area. So now sometimes what happens beta, if the lower pole of the thyroid enlarges, and because of enlargement from the lower pole of the thyroid gland, there is a possibility that this may enlarge and there may be some growth behind the sternum. That is what we call as retrosternal goiter. If there is somebody sitting behind the sternum, this may put pressure on the trachea and the esophagus, dyspnea, dysphagia. This may put pressure on the larynx, because of which the air may rush out through the vocal cords and may produce some noise which we call as stridor. Sometimes this goiter behind the sternum may put pressure on the superior vena cava, and this may cause blockade of the superior vena cava, because of which the neck veins and the facial veins may get engorged and dilated. We may see these type of presentations. Sometimes what we can do is, if this mass is putting pressure on the veins, we can elicit one Pemberton's test. In Pemberton's test, we ask the patient to raise the hands multiple times above the head. Now, when you are asking the patient to raise the hands multiple times above the head, can you do it where you are sitting? Right. So, if you raise the hands multiple times like this will put pressure on the vena cava, and suddenly the blood flow towards the heart will reduce and the blood will get pooled here in the facial neck region, and there will be flushing of the face. So you can just compare flushing of the face on raising both the hands above the sternum. That simply means that there is somebody sitting behind the sternum here which is putting pressure on the major vessels. This is what is Pemberton's test, which helps us in identifying whether the patient is having some mass behind the sternum or not. This is positive in retrosternal goiter. In the treatment for these retrosternal goiters also, we have to do the same thyroid surgery. So we can make an incision in the lower part of the neck, and by this incision, when we are dissecting the thyroid gland, if suppose we put our index fingers down, then it is possible to pop this retrosternal goiter up into the incision, and this retrosternal goiter can easily be taken out from this neck incision only. So beta ji, in retrosternal goiter, this is the enlargement of the thyroid gland, usually the lower pole of the thyroid gland, which extends behind the sternum. Patient may present like here, what is being shown. It is the enlargement from the lower pole of the thyroid gland, and this is extending behind the sternum. The patient may present with dyspnea, dysphagia, engorged neck and facial veins, and we may find this positive Pemberton's test. This is flushing of the face, on raising both the hands above the head. And the treatment of this retrosternal goiter is just like what we are doing treatment for the goiters. We can remove these retrosternal goiters by neck incision itself. There is no need to open the sternum and remove these retrosternal goiters. Some precautions while we are doing thyroid surgery. For example, whenever thyroid surgery is done, we have to ensure that patient does not have hyperthyroidism. Hyperthyroidism means increased T3, T4 levels in the blood. Why this is important? Let us just try to understand some story related to this thyroid surgery. If suppose patient is having more T3, T4 in the circulation and you want to remove the thyroid gland, you take this patient in the operation theater. When you are handling the thyroid gland for thyroidectomy during the operation, there will be more liberation of T3, T4 from the follicles into the blood. If pre-existingly there is increased T3, T4 in the blood, and on handling the thyroid, more T3, T4 is coming into the blood, this can lead to serious high levels of T3, T4 in the circulation. And suddenly a thyroid storm can come, a thyrotoxic crisis can occur. That is the reason why we do not want to take a hyperthyroid patient for surgery. As a surgeon, it is important that before thyroid surgery, we have to bring down this T3, T4 levels to normal. In order to bring this T3, T4 levels normal before surgery, we can take the help of various medicines. We can use anti-thyroid drugs like carbimazole, methimazole, propylthiouracil. Propylthiouracil was a question on 4th of June, though it was a pharmacology question, first trimester of pregnancy, which is the anti-thyroid drug of choice. So that was a propylthiouracil. We can use iodide to reduce the vascularity of the gland. We can use beta blockers also when rapid control of T3, T4 is required. Now, beta blockers in thyroid, yes, beta blockers like propranolol, they do not have any action related to synthesis of thyroid hormones, but they have got a peripheral action. Whatever T4 is there in the circulation, these beta blockers inhibit the peripheral conversion of T4 to T3. That means the biologically active form T3 will not form if you are giving beta blockers. Whenever beta blockers are used to control the thyroid hormones, then we have to continue these beta blockers for 7 days after thyroidectomy has been done. That means till 7 days after the operation, we have to continue these beta blockers, because till the time thyroid gland was taken out, the thyroid gland was still producing T3, T4. So in the blood, the T3, T4 levels will still be high. And that is why if you are using beta blockers to reduce T3, T4, you continue these beta blockers for approximately up to 7 days after the operation. Right. Suppose we have made the patient euthyroid and now we are doing the surgery. Surgery for thyroid is done under general anesthesia. That means we are putting an endotracheal tube, and there can be some complications by the surgeon in this thyroid surgery. Sometimes what happens, there may be hemorrhage taking place. For example, if you are doing the thyroid surgery, sometimes what can happen, suppose I say that this is the right lobe of the thyroid and here is the left lobe of the thyroid. Now, if this is the right lobe of the thyroid, there are two thyroid arteries, the superior thyroid artery and the inferior thyroid artery. Superior thyroid artery is coming at the superior pole of the thyroid gland. You have made an incision in the lower part of the neck. You have made an incision somewhat like this. And now you are raising the skin flap. You are doing the dissection inside. When you are dissecting near the upper pole, suppose I say that this is one lobe of the thyroid gland here. When you are dissecting the upper pole, the superior thyroid artery may be lying somewhat like this. Since the incision which you have made is in the lower part of the neck, so many a times what happens, you are not able to see the superior thyroid artery nicely, so you are not able to put a ligature or a suture on the superior thyroid artery nicely. And suppose the ligature here is loose. Now what can happen after the operation? If suppose the ligature here is loose, operation is done. At the time of operation, there was nothing significant, there was no bleeding, nothing. So you closed this incision after removing the thyroid gland. Patient is extubated. That means patient is taken out of general anesthesia. The endotracheal tube has been out. Patient is conscious. Patient is shifted into the recovery room. Then patient is shifted into the ward maybe after 4 hours of surgery. Now when the patient has gone into the ward, the attendants are coming. The attendants are trying to meet this patient. They want to know how is everything. So when these attendants are talking to the patient, and the patient is also telling, yeah, everything was comfortable, the surgeon was really good, I did not have any problems and all that stuff. Suddenly sometimes what can happen, beta? Because of the endotracheal tube, there might be some hacking in the trachea. So the patient is having some irritation in the trachea, and suddenly suppose the patient coughs. Something like this. If the patient coughs, now there is sudden exertion in this area. And if the ligature here was loose, the ligature can slip and the superior thyroid artery can open up and it can start bleeding. The bleeding is taking place just beneath the skin here. A blood clot is developing in this area. And there is a possibility that very soon this blood clot may start putting pressure on the trachea. And if the trachea is getting compressed, the patient will not be able to breathe. And suddenly on the evening of thyroid surgery, we find that patient is going into respiratory distress. Earlier, a few minutes back, patient was absolutely fine. He was talking to the relatives nicely. But suddenly what has happened? Because of slipping of the ligature from superior thyroid artery, there is bleeding and the blood clot is putting pressure on the trachea. And now the trachea is getting compressed. And the relatives are seeing, oh my God, what the hell is happening? Patient is not able to breathe. And the relatives are running around. Where is the doctor? Where is the doctor? And suppose you are the resident doctor and you are having your coffee with your girlfriend or your boyfriend. And suddenly you find that some relative is coming, running towards you, and he just takes you from your collar and he just pulls you towards the patient, and you see the patient, oh my God, what has happened? Oh my God, this patient is dying. Now, if you know this complication, that this can be because of compression of the trachea by a large blood clot, maybe due to slipping of a ligature, what we need to do immediately? Immediately, you will open the skin sutures. Whatever sutures were there in the skin, you will immediately open the skin sutures. As soon as you open the skin sutures, the clot which was there inside will immediately come out. As soon as the clot comes out, the pressure on the trachea is relieved. And the patient is saved. And the relatives are looking at you. Oh my God, what a doctor you are. He actually went up, but you saved him. You are the second God. You saved this patient. 17th of December, my dear doctors. The examiner may frame such type of clinical scenarios. Doctor, if on the evening of thyroid surgery, you suddenly find that patient is going into respiratory distress, what should be the immediate step you would like to take? Immediately, we would like to open up the skin sutures, evacuate this blood clot, release the pressure on the trachea, and save the life of your patient. This type of bleeding, which occurs 4 to 24 hours after the operation, is called as reactionary hemorrhage. Actually speaking, beta, there are 3 types of hemorrhages: primary, reactionary, and secondary. Primary is something which occurs during operation, reactionary within few hours, 4 to 24 hours after the operation, and secondary which occurs after 24 hours of operation. The reason for respiratory distress apart from this hemorrhage can be something else also. During thyroid surgery, there is a recurrent laryngeal nerve. If you are doing a total thyroidectomy, if you injure both side recurrent laryngeal nerve, then the vocal cords will be paralyzed and the patient can die. On the operation table, if you have injured both the recurrent laryngeal nerves, at the time of operation there is an endotracheal tube inside. The anesthetist is pumping oxygen through the endotracheal tube. So you may not even come to know that you have damaged both the recurrent laryngeal nerves. But what can happen? You have done the surgery, you have done the closure and everything, and now you are just de-scrubbing yourself, you are removing your gloves and everything, and the anesthetist is trying to take the tube out. As soon as the anesthetist takes the tube out, the vocal cords paralyze, they medialize, and the airway blocks. No oxygen going inside. The patient oxygen saturation dips quickly, and the anesthetist is looking. Oh my God, what is happening? As soon as I am taking the tube out, the patient oxygen saturation is going down. And the anesthetist is getting confused. What the hell is this? Then he asks the surgeon, "Doctor, did you injure the recurrent laryngeal nerves on both the sides?" And then we have to do surgical correction, right? So the examiner may cook some clinical stories that if the anesthetist is not able to extubate the patient after thyroid surgery, what can be the likely cause? Why the patient is going in respiratory distress? Probably the surgeon would have injured both the recurrent laryngeal nerves. However, the most common nerve injured during thyroid surgery is the external branch of superior laryngeal nerve. There has been a huge controversy regarding which is the commonest nerve injured, whether it is a superior laryngeal or it is a recurrent laryngeal. So it is the superior laryngeal nerve. And also after doing a total thyroidectomy, obviously the patient will become hypothyroid. For this, we have to give thyroxine hormone for the whole life of this patient after surgery. So thyroxine replacement is required. Sometimes hypoparathyroidism can occur after total thyroidectomy. We know the parathyroid glands. They are small, yellow-colored, peanut-sized, located on the posterior aspect of thyroid gland at the superior pole and the inferior pole. When you are dissecting the thyroid gland, many times you cut the blood supply to the parathyroids. And then the patient may develop parathormone deficiency. Sometimes, accidentally, we might remove this parathyroid. Though we wanted to remove only the thyroid, but while doing the surgery, if the surgeon focus shifts towards the staff nurse, he might land up in removing the parathyroids also. Sometimes what happens, if suppose parathyroids have been removed and they are lying just here, they are 5 mm yellow colored just like fat. After the surgery is done, before closing the incision, when the assistant of the surgeon is washing that area, just to clean up, just to see whether proper hemostasis, proper bleeding has been secured or not. So the surgeon might be chatting with the staff nurse on one side, and the anesthetist is, the assistant is cleaning all this area. Suddenly the assistant notices that there is a 5 mm yellow colored something here. And when the assistant is washing with normal saline and using that suction tube to suck out the normal saline, suddenly the assistant notices this 5 mm yellow color has gone into the suction tube, and this 5 mm is going into the suction tube, and the assistant thinks that this is parathyroid. He informs the surgeon, "Sir, dekho wo ja raha hai. See, parathyroid is going in the suction tube." And by the time the surgeon comes and looks, the parathyroid may have gone into the suction bottle. Even if the parathyroid has gone into the suction bottle, then also we just open the suction bottle, put our hand inside, and remove that parathyroid. and then wash it with normal saline, and then put this parathyroid back in any muscular part inside. If the incision is open, we put this parathyroid in the sternomastoid muscle, but if the incision has been closed, then we put this parathyroid in the arm muscle or the forearm muscle, and we put a marker here so that the patient remembers for the whole life that his parathyroid is either lying here or maybe lying here. Right? Let's write something about these different complications. What we'll do is we'll try to find out some space. Like suppose this is the space we can use here. You can use the space, the blank page is what you would be having. Maybe after the topic of vascular surgery. This image is something which is not relevant here. Some important points related to thyroid surgery. Make the patient euthyroid. U means normal T3, T4 levels before surgery to avoid thyroid storm or thyrotoxic crisis. And for doing this, drugs which can be used we can use anti-thyroid drugs like carbimazole, methimazole, propylthiouracil, but generally we prefer using this methimazole, and these drugs are given up to evening before surgery. These drugs are given up to evening before surgery. We can use iodides. They reduce vascularity of the gland and they are given up to morning before surgery. We can use beta blockers. They inhibit peripheral conversion of T4 to T3. So these medicines are given for up to 7 days after surgery. These medicines are given for up to 7 days after surgery. Various complications of thyroid surgery. Like reactionary hemorrhage, this is due to slipping of a ligature from superior thyroid artery which leads to respiratory distress, few hours after the operation. This will require immediate treatment by opening of skin sutures. This will require immediate treatment by opening of skin sutures. Another complication what we can come across is respiratory distress. This can be because of damage to both this respiratory distress beta. This can be due to damage to both recurrent laryngeal nerves during the operation, the anesthetist will not be able to extubate the patient after operation. Another reason for respiratory distress is reactionary hemorrhage. This occurs few hours after the operation. Apart from this, another reason for respiratory distress after thyroid surgery is hypocalcemia. But this is a late complication. This is seen 2 to 5 days after operation. 2 to 5 days after operation. Another complication, what we can see after thyroid surgery, injury to nerves, most commonly it is the external branch of superior laryngeal nerve. External branch of superior laryngeal nerve which is getting injured. And second most commonly, it is the recurrent laryngeal nerve. In thyroid surgery, there may be injury to nerves, most commonly the external branch of superior laryngeal nerve, second most commonly the recurrent laryngeal nerve. Another complication what we can come across just give me a moment. Right. Another complication what we can come across, hypothyroidism. Hypothyroidism. This require lifelong thyroxine replacement. This required lifelong thyroxine replacement. Another complication, hypoparathyroidism. This is rare. Most common cause is ischemic injury, that is during dissection if we cut the blood supply of this parathyroid. And second most commonly, accidental removal of parathyroid. Now here, if there is accidental removal of parathyroid, then also we have an option. We can re-implant the parathyroid back into the muscle. This can be either sternomastoid or forearm or arm muscle. These are the various complications which we can come across in thyroid surgery. I do understand, Beta, that you might be facing a space crisis here, but I think this is the area where the major space crisis is there. And generally, we talk about this pre-op preparation and complications of thyroid surgery when we talk about thyroid cancers. But I thought that it's better that since we are reading this thyroid in surgery for the first time, let us note these complications here itself rather than talking about in cancers. Okay, right, Beta. So I hope you have not missed out. I hope you are able to write this, Beta. Right. Now, since we talked something about reactionary hemorrhage here, so I feel that let me also give you some information about these different types of hemorrhages here. This is something not restricted to the thyroid, but this is a general story. Like we talked about this hemorrhage story in the chapter of trauma. So the different types of hemorrhage: primary hemorrhage, this is bleeding during operation. So this is easily understandable, Beta. If you are cutting anything, it can bleed. Reactionary hemorrhage, this is bleeding within 4 to 24 hours after the operation. And the causes of this bleeding: slipping of a ligature, another cause, dislodgement of clot, another cause, rise in blood pressure. Suddenly after the operation, if the ligature slips, or if the clot dislodges, or if the blood pressure rises, the patient can bleed 4 to 24 hours after the operation. And the third one is the secondary hemorrhage. This is bleeding which occurs after 24 hours of operation. And the reason for this is infection. Reason for this is infection. In the post-operative period, suppose you are doing surgery for piles or hemorrhoids. You know this anal canal is a dirty area. So whenever we are doing surgery for these piles, there is a possibility that infection occurs in the surgical area and bacterial multiplication in that area. The bacteria may erode the wall of the vessel and that can bleed. So because of infection, there may be necrosis or erosion of the wall of the blood vessel. Necrosis or erosion of the wall of the blood vessel. These were some important points I thought to share. This is about the story of thyroid, what we discussed. Now let's talk something about the story of breast. I hope, beta, you have not missed out something. If by chance you have missed out something, just let me know, beta, so that I would be happy to share this again, the screen again with you. If by chance anybody has missed out, please take your time, try to note the things down. Let me just remove myself for a moment. Right, beta. So I hope you have written about this. Right, beta. So moving from this thyroid, now let's go into the breast and let us try to understand what all we are going to discuss here. Let's take a look at first the images. Right, beta. So in this story, if we just try to take a look that what all we are going to discuss here, let us try to understand that first. Breast is a topic, beta, which is mainly discussed in surgery only. So in anatomy also partially we take up about the lymphatic drainage and the basic anatomy of the breast. So we'll be doing a revision of the anatomy here as well. And we will be taking a look at all the pathologies possible inside the breast. First, if we focus on the anatomy of the breast, breast is a modified sweat gland. This breast lie in the superficial fascia. There are two layers of the superficial fascia, the superficial layer and the deep layer. For example, this what you're seeing is the skin. Just beneath this is the superficial fascia, which has got two layers. The superficial layer is lying just beneath the skin and the deep layer is lying right at the pectoralis major muscle. So the entire breast is enclosed within the two layers of the superficial fascia. Breast rests on the pectoralis fascia. So if you take a look at the structures from anterior to posterior, there is skin, then there is superficial layer of superficial fascia, then the breast, the deep layer of superficial fascia, that is the pectoralis fascia, then lies the pectoralis major muscle, which forms the major contour of the chest. Behind the pectoralis major is the pectoralis minor muscle, and behind the pectoralis minor lie the ribs, and in between the ribs there are intercostal muscles. If we take a look at the extent of breast, for the extent of breast, beta, we define it as anatomical extent and surgical extent. Now, anatomical extent, it is from the second rib above to the sixth rib below. Horizontally, from the lateral border of sternum to the anterior axillary line. But when we say surgical extent, then in the surgical extent, we are talking about surgery for breast, and most common surgery what we are doing for breast is for breast cancer. That is a modified radical mastectomy where we have to remove the entire breast, and whenever we are doing a cancer surgery, in cancers we have to take an adequate margin all around. So the surgical extent of breast will be different than the anatomical extent. The surgical extent will be more in all directions. So if we take a look vertically, surgically, breast extends from the clavicle above to 7th to 8th ribs below, and horizontally it extends from the midline up to the edge of latissimus dorsi muscle. So I repeat, beta, if you look at the anatomy of breast, anatomical extent 2nd rib to 6th rib, but surgical extent clavicle to 7th to 8th ribs. Horizontal extent anatomically from this horizontally anatomically from the lateral border of sternum to the anterior axillary line, and surgically from the midline up to the edge of latissimus dorsi muscle, right? So this is basically the extent of breast. Now, breast can be divided into various quadrants, beta. Like we can divide the breast into 4 quadrants. The upper outer quadrant, the upper inner quadrant, the lower inner quadrant, and the lower outer quadrant. Some part of the breast extends into the axilla, which we call as axillary tail of Spence. In the center of the breast is the areola, which is the dark pigmented portion which has got the Montgomery tubercles, that is the sebaceous glands, which enlarge during pregnancy and lactation and serve to lubricate the nipple. And in the center of the areola there is nipple, which has got smooth erectile tissue. Inside the breast there are 3 things. There are lactiferous ducts, the lobules, and these duct and lobules are supported by the supportive connective tissue, that is the stroma. And in this supportive connective tissue there are suspensory ligaments, right? If we take a look at the lymphatic drainage of breast is drained mainly by 2 group of lymph nodes. One is the axillary group, another is the internal mammary group of lymph nodes. 80 to 85% of the breast is drained by the axillary group. 15 to 20% of the breast is drained by the internal mammary lymph nodes. Especially the posterior part and the medial part of the breast are drained by the internal mammary lymph nodes. The axillary lymph nodes can be divided into 3 levels on the basis of this pectoralis minor muscle. The lymph nodes which are lying below and lateral to the pectoralis minor, they are level 1. Those lymph nodes which are situated at the pectoralis minor are level 2, and those lymph nodes which are situated above and medial to pectoralis minor, they are level 3. So beta, how many level of lymph nodes in the axilla? 3 levels. Level 1 below and lateral to the pectoralis minor, level 2 at the pectoralis minor, and level 3 above and medial to the pectoralis minor. Apart from this, we can divide these lymph nodes into 5 groups. The anterior group, this would be lying along the pectoralis, along the lateral thoracic vessels. See, these are the different lymph nodes what we are seeing here all over. There are lateral thoracic vessels going here. The lymph nodes which are situated here are called as the anterior group. Posteriorly there is a subscapular vessel, so this lymph node will be posterior. This lymph node will be called as lateral, it is along the axillary vein. The lymph node in the center of the axilla will be central, and lymph nodes which are situated just below the clavicle here, they will be called as the apical lymph nodes or the infraclavicular lymph nodes, right? So this is the brief outline about the anatomy of breast. Now what we do here beta is, I think let's take a break before we move further into the breast, and let's take a nice break here. Relax yourself and we'll be back. At 6:35 p.m. Okay, the Indian Standard Time, 6:35 p.m. We'll be back. Thank you very much for your patience. Right, beta. So we are back, and we were discussing about the basic anatomy of the breast, and we were discussing about the lymphatic drainage story, beta. I was just trying to explain that how axilla is one of the major group of lymph nodes draining the breast, and depending on the location of the lymph nodes, for example, those lymph nodes which are present over the lateral thoracic vessels, these are called as anterior lymph nodes. Those which are present here posteriorly along the subscapular vessels, they are called as the posterior lymph nodes. Those lymph nodes which are present along the axillary vein, these are the lateral lymph nodes. Those which are in the center of the axilla, they are the central lymph nodes. And those lymph nodes which are present below the clavicle, they are infraclavicular or apical lymph nodes. Why this is important for us to understand better? Because when we are talking about a breast cancer story, now suppose this tissue, what you are seeing here, this is actually the breast tissue. If there is a cancer developing inside the breast, there is a possibility that these cancer cells will be traveling through the lymphatics, and through the lymphatics, this may be going into the anterior lymph nodes, or maybe going into the lateral lymph nodes, or the central lymph nodes, or the posterior lymph nodes. And this apical lymph node, this is the most important subgroup in the axilla, because this apical is receiving the lymph from all the other lymph nodes. So if by chance you come across a situation where apical lymph nodes are involved in breast cancer, that means all the other lymph nodes are vulnerable which would have been involved in cancer. So it is our duty that if apical lymph nodes are involved, we have to remove all the lymph nodes of the axilla, right? Okay, beta. Now let us take a look what all is written in the anatomy here. Breast, beta, we discussed it as a modified sweat gland. It lies between the two layers of superficial fascia. It rests on the pectoralis fascia. If we take a look at the extent of breast, the anatomical and surgical, if suppose this is the actual location of the breast, beta, and some part of the breast we know it goes into the axilla as well, so this would be the axillary tail of Spence. Now anatomically, if we take a look, then vertically breast extends from second rib above and it goes up to the sixth rib below, and horizontally it extends from the lateral border of sternum up to the anterior axillary line. But here what we are seeing in the surgical extent, if this was the actual breast, and when we are doing surgery for breast, if we talk about surgery for breast cancer, then we have to take adequate margin all around this cancer. That means the surgical extent of breast is different from the anatomical extent of breast. And surgically, beta, we start from the clavicle above up to 7th or 8th rib below, and here from the midline up to the edge of latissimus dorsi muscle. Right. In the center of the breast, if suppose we say that this is the breast tissue, and this is the axillary tail. Now in the center, beta, there is a dark pigmented area which we call as the areola. In this areola, there are sebaceous glands. These sebaceous glands, they enlarge during pregnancy and lactation, which are called as the Montgomery tubercles. They secrete sebum, so they serve to lubricate the nipple. In the center, there is nipple. Nipple consists of smooth erectile muscle. That is why this is a erectile tissue. Now this Montgomery tubercles, beta, this is something which is asked in the OBG FMG paper. Apart from this, we can divide the breast into 4 quadrants, what we talked about. If suppose I say this is the breast, we can divide this breast into 4 quadrants. The upper outer quadrant is the most important quadrant for a surgeon because this is the commonest site for breast cancer, while the least common site for breast cancer is the lower inner quadrant, right? So this is the upper outer quadrant and this is the lower inner quadrant. Upper outer quadrant is the commonest site of breast cancer and lower inner quadrant, UOQ beta, UOQ, this is the upper outer quadrant and LIQ will be the lower inner quadrant, right? This is the least common site of breast cancer. Now if we go inside the breast and try to take a look what all God has given inside the breast. Suppose this is the breast tissue. We know that breast rests on the pectoralis fascia. So behind there would be the pectoralis fascia and behind this there would be the pectoralis major muscle. If we take a look inside the breast, God has given the lactiferous ducts. These lactiferous ducts, they are converging at the nipple. There is a lobule here. And these duct and lobule inside the breast, they are supported by the supportive connective tissue which we call as the stroma. And in this stroma, there are ligaments beta which are extending from the underlying fascia right up to the skin, and they help in holding of the breast as well. These ligaments are called as suspensory ligaments or the Astley's or Cooper's ligaments. In the lymphatic drainage of breast, we can just make a note here beta. The lymphatic drainage. Axillary group drains 80% of breast. Internal mammary group that drains 20% of the breast, mainly the medial and the posterior part of breast. So if there is a cancer in the medial part of breast, there are more chances of involvement of the internal mammary lymph nodes. In the axillary group, there are 3 levels. And there are various subgroups. In the subgroups, we have got anterior, posterior, central, lateral, and apical lymph nodes. We can make a note here. The interpectoral, that is the lymph nodes which are present between the pectoralis major and pectoralis minor, the interpectoral lymph nodes, they are also called as Rotter's lymph nodes. Rotter's lymph nodes. Rotter's lymph nodes. If we take a look at the different congenital problems in the breast, there can be amasia, polymasia, athelia, polythelia. So here beta I would like to tell you, masia, mestia, this is something we use for breast, and thelia is something we use for the nipple. A we understand beta, it is absent, and poly we understand multiple. So amasia is absence of breast, polymasia is multiple breast, athelia is absence of nipple, polythelia is multiple nipple. Amasia, there is one syndrome which can be seen more commonly in males sometimes, that is the Poland syndrome. This is amasia, that is absence of breast along with absence of sternal part of pectoralis major muscle. This Poland syndrome is more common in males. Poland syndrome is more common in males. Right. Now, if we talk about the multiple breast and multiple nipples beta, then we should know there is one line which we call as the milk line beta, and this milk line extends from the axilla into the groin. So from where to where this is going beta? This is extending from the axilla to the groin, and multiple breasts are commonly seen along this line. Most commonly, multiple breasts are seen in the axilla. Second most commonly, they are seen in the groin. And third most commonly, they are seen in the mediastinum. So if there has to be multiple breast or multiple nipple, then they are more common along the milk line. And this milk line extends from axilla to the groin. Milk line extends from axilla to groin. Most commonly axilla, second most commonly groin, and third most commonly mediastinum. So this was just a passing reference about the congenital problems what we can come across in the breast. Now beta, let's take a look that you are going to be the doctor in February 2023. Practicing in the hospital. You are already a doctor, but you'll be practicing in the hospital in February 2023. Now, how you can come across different type of patients, different type of females presenting with breast problems. So if we just try to analyze beta, let me just remove this video from this screen from here, and let us just try to understand the different pathologies, how you are going to see these different pathologies in a female. So beta, can you just tell me what are the different structures inside the breast? Lactiferous duct, lobule, and this supportive tissue, that is the stroma. That means one thing which is very clear in our mind, that a female presenting with breast problem, the problem can arise only from these three structures: duct, lobule, stroma. Right. Now just try to imagine beta, February 23, when you are sitting in the OPD and a female comes to you with some or the other breast problem. What can be the common problems inside the breast? क्या हो सकती है? There might be breast pain. Pain is something we use ALGO. So breast pain, mestalgia. Okay. So the female can come to you with pain in the breast. Female can come to you with something coming out of the nipple, maybe some discharge coming out of the nipple, maybe milk, excessive milk coming out, or maybe serous discharge coming out, green discharge, brown discharge, black discharge, blood discharge coming out from the nipple. Or very commonly, females come with a lump inside the breast. Breast में गठान हो जाती है, आंचल में गठान होती है. Now, let us try to understand that why these problems occur. What is actually mestalgia? Now, this breast pain, this we can classify as cyclical mestalgia and non-cyclical. Cyclical means which is related to menstrual cycle, and non-cyclical which is not related to menstrual cycle. We all know, beta, that every female, every month, the hormone level fluctuates. They go up and they come down. When the hormone levels are going up, this causes hyperplasia of cells inside the breast. And when the hormone levels go down, then whatever hyperplasia has occurred, that undergoes involution and the story becomes normal. I repeat this in Hindi, beta. हर महिला हर महीने जो मेंसेस आते हैं उसमें हम देखते हैं कि हर महिला में हर महीने हार्मोन का लेवल बढ़ता है, गिरता है. जब ये ईस्ट्रोजन प्रोजेस्टेरोन का लेवल बढ़ता है तो ब्रेस्ट के अंदर जो सेल्स हैं उनका हाइपरप्लेजिया होता है, और जब ईस्ट्रोजन प्रोजेस्टेरोन का लेवल गिरता है तो जो हाइपरप्लेजिया हुआ था वो वापस से इन्वॉल्यूट हो जाता है और कहानी नॉर्मल हो जाती है. ये प्रक्रिया निरंतर हर महीने हर महिला के ब्रेस्ट में चलती रहती है. जब कोई लड़की छोटी उम्र पे होती है, जब उसके ब्रेस्ट का डेवलपमेंट हो रहा होता है या अभी हुआ ही होता है, उस समय ऐसा हो सकता है कि ब्रेस्ट उन हार्मोनल चेंजेस को अडॉप्ट कर रही है. तो जो यंग लड़कियां होती हैं उनमें जब पूरी तरह से अडॉप्टेशंस नहीं हो पाते तो कई बार ऐसा देखा गया कि जब ये महीने में हार्मोन का लेवल बढ़ता है और हाइपरप्लेजिया होता है तो इन लड़कियों को ब्रेस्ट में थोड़ा दर्द होता है, लेकिन जब उस महीने में हार्मोन का लेवल गिरता है तो कंजेशन कम हो जाता है और दर्द ठीक हो जाता है अपने आप. इसको अपन बोलते हैं साइक्लिकल मेस्टाल्जिया. आई रिपीट दिस इन इंग्लिश. Especially in young girls, when the breast is developing or the breast has just developed, the body is trying to adapt to the changing level of hormones. The breast is also trying to adapt to the changing level of hormones. So every month, especially during the early years of life, there is a possibility that when during the month the hormone levels are increasing, the hyperplasia of cells is taking place. At that time, this girl might be having some congestion inside the breast. But when during the month the hormone levels are falling down, whatever hyperplasia has occurred, that is undergoing involution, and then this congestion will resolve and the pain disappear. This type of pain, which varies with the phases of menstrual cycle, this is what we call as cyclical mestalgia. As a doctor, we should know, because February 23, you might come across a 15-year-old girl or a 18-year-old girl or a 25-year-old girl who might come to you that, doctor, I'm having pain in my breast. Every month, there are certain days where I feel more pain inside the breast. What we need to do is, we need to reassure these patients. Don't worry. Your body is trying to adapt to the changing level of hormones. It may take some months, but things will settle down. So you just reassure these patients. Generally, no treatment is required for cyclical mestalgia. If the girl is really worried and the pain is really severe, then you can give some decongestive agents like tablet of oil of evening primrose, If the pain is really very severe, you can do some hormonal manipulation by giving danazol and bromocriptine. And rarely there is a possibility that patient might be having very severe pain and she is not responding to any type of medications. In those cases, we might start thinking the role of tamoxifen. Tamoxifen is something we use in breast cancer. This is anti-estrogen. This anti-estrogen can also be used in intractable cases of cyclical mastalgia. Right. So this is a story of cyclical mastalgia. Non-cyclical. That means no relation with the monthly cycle. That means no relation with the hormones. Must be something related to acute inflammation. Now, if you look at the acute inflammation, you can start thinking from the skin. There might be something in the skin which is causing pain. There might be some inflammation of the veins in the skin, which is called as a Monders disease. That is actually thrombophlebitis of the superficial veins of the skin of the breast and the chest wall. There might be inflammation of the breast inside. That is mastitis. There might be inflammation of the pectoralis major muscle, minor muscle, myalgias. There might be inflammation of the ribs inside. There is a Tietz disease which is costochondritis of the second rib. So these inflammatory conditions can lead to pain. Here in beta, I would like to show you one image, two images rather. Herein, what you're seeing in this particular image beta, you are seeing a cord-like structure here. Can you appreciate this cord-like structure? This is actually inflammation of the superficial vein of the skin of breast. And this is what we call as Monders disease. Monders disease. This has nothing to do with the hormones, right? We give anti-inflammatory to treat this condition. This image, what you're seeing beta here. Now this is an image of mastitis. You can see the signs of acute inflammation beta. Rubor, tumor, calor, dolor. Can you see how this breast has become red hot, engorged, and it would be really painful. When do we come across these mastitis type of situations? Now herein, during pregnancy and lactation, we do understand that breast is getting engorged with milk. Sometimes what can happen, especially during lactation, if the Montgomery tubercles at the areola, they are not able to secrete sufficient sebum, there might be dryness in the nipple. And if the lady is not using any external lubricating agents, the dryness in the nipple will persist. Cracks can develop in the nipple. And now when the baby takes the feed, then Staph aureus from the baby's mouth can travel through the cracks in the nipple and go inside the mother's breast. And as soon as the Staph aureus goes inside the mother's breast, there is milk everywhere. And the staph party starts. And this bacterial party inside the breast causes mastitis. Signs of acute inflammation: redness, swelling, raised temperature, pain. This is the presentation of mastitis. I repeat this story in Hindi. Mastitis, जैसा कि हम देख पा रहे हैं कि किस तरह से ब्रेस्ट गुस्से से लाल सूज गई है, टेम्परेचर बढ़ा हुआ होगा, पेशेंट को दर्द होगा. ये जो कहानी है ये अक्सर प्रेगनेंसी और लैक्टेशन में ज्यादा देखने को मिलती है. खासकर अगर हम लैक्टेशन की बात करें बेटा, जब मां अपने बच्चे को दूध पिलाती है, अगर मान लीजिए जो मां के ब्रेस्ट के एरियोला में मोंटगोमेरी ट्यूबरकल्स हैं, अगर वो सफिशिएंट मात्रा में सीबम नहीं प्रोड्यूस कर रहे हैं तो निपल पे लुब्रिकेशन नहीं हो पा रहा है, जिसकी वजह से निपल ड्राई, सूखा है. अगर ये मां अपने निपल को मॉइस्ट नहीं रखती है, कोई एक्सटर्नल लुब्रिकेंट्स का इस्तेमाल नहीं करती है, तो निपल के सूखे होने की वजह से निपल में क्रैक्स पड़ना शुरू हो जाते हैं. अगर मान लीजिए निपल में क्रैक पड़ गए हैं, जब ये माँ अपने बच्चे को दूध पिलाएगी, जब बच्चा दूध पीता है तो बच्चे के मुंह के अंदर जो स्टेफ ऑरियस है वो इस निपल के क्रैक से होता हुआ माँ के आंचल में चला जाता है, और जैसे ही ये स्टेफ ऑरियस बैक्टीरिया माँ के ब्रेस्ट के अंदर चला जाता है, माँ के ब्रेस्ट के अंदर दूध ही दूध भरा होता है और ये बैक्टीरिया की उस दूध में पार्टी शुरू हो जाती है और उसकी वजह से ब्रेस्ट ऐसे लाल गुस्से से सूज जाती है, एक्यूट इन्फ्लेमेशन हो जाता है जिसको अपन मेस्टाइटिस बोलते हैं। If the lady comes to you at the stage of mastitis, you can give adequate antibiotics to kill that bacterial party, and you advise the lady to wear a nice breast support so that the breast does not hang much. If by chance this lady does not present to you at the stage of mastitis, like in our country, we do understand that females are quite shy and they do not report their breast problems to the doctor. जैसा कि हम जानते हैं बेटा, हमारे देश में महिलाएं शर्म करती हैं और वो सोचती हैं कि जहां तक हो सके इस तरह की समस्या किसी से ना शेयर किया जाए। और मान लीजिए मेस्टाइटिस होने के बाद भी ये महिला डॉक्टर को नहीं दिखाती हैं, कोई दवाइयां नहीं लेती हैं, शी इज नॉट टेकिंग एनी एंटीबायोटिक। सपोज नाउ the staph party is continuing inside and the party is increasing. Gradually the staph will start causing necrosis here and there inside the breast, and small pus pockets may develop inside the breast at multiple places. Abscess, pus, this is what we call as early stage of breast abscess, when small pus pockets develop inside the breast. ध्यान दीजिएगा बेटा, मेस्टाइटिस हुआ था, अगर एंटीबायोटिक दे दी गई होती ठीक हो जाती, लेकिन अगर एंटीबायोटिक नहीं दी गई तो ये बैक्टीरिया की पार्टी चलती रहेगी और धीरे धीरे बैक्टीरिया अंदर के टिश्यू को खाना शुरू करेगा और छोटी छोटी पस की पॉकेट्स जगह जगह पे डेवलप होना शुरू हो जाएंगी। एट दिस स्टेज इफ द लेडी कम्स टू यू, वी शुड नो that pus anywhere inside the body, we have to drain this pus. पस को देख के सर्जन को कुछ होता है, पूरी बॉडी में पस कहीं भी हो हमें उसको निकालना होता है। If we are talking about small pus pockets here and there inside the breast, we can do ultrasound and then we can do multiple needle aspirations and aspirate this pus. This is what we do in the treatment for early breast abscess. Needless to specify that antibiotics would definitely form a crucial part in the management. If by chance, suppose, the lady does not report to the doctor in mastitis or maybe in early stage of breast abscess, the staph party is continuing, there is a possibility that now there is more amount of necrosis taking place and a good amount of liquid pus collection develop inside the breast. If good amount of liquid pus collection develop inside the breast, now in this particular situation, now in this case, what will happen? When we examine this patient, a sign of fluctuation will be present. Whenever there is any swelling over the body which has got liquid inside, if you try to press on one side and feel on the other side, if you press from one side, then you will feel the liquid pressure on the other side. This is what we say that fluctuation is positive. And if there is good amount of liquid collection inside, then we have to make an incision and drain this pus. Needless to specify the role of antibiotics. And this is what something asked on 4th of June 2022. My dear friends, we'll see what all is written in the workbook, but I think I'll take approximately 15 minutes time. Just grant me 15 minutes time and I'll be back, because there's certain students who are waiting. It's a proud moment for us because they've cracked this FMG exam, and it is my duty that if I can meet them, I can share their thoughts and their happiness for a few moments. Just give me 15 to 20 minutes time, beta. I'll be back by 7:30 to 7:35. I'll update you the exact time. Thank you. Hello. Yeah. So, beta, if we take a look that what all we have discussed in mestalgia story, the cyclical mestalgia, the non-cyclical mestalgia, let us see what all is written in the workbook here. If we take a look here, beta, the cyclical mestalgia, which one would be related to hormones, beta, cyclical or non-cyclical? Very good, cyclical. So this is due to hormonal influence. And the cyclical mestalgia will be varying with the phases of menstrual cycle, right? Since this is related to hormones, beta, we just advise reassurance to the patient. Sometimes we have to prescribe tablets of oil of evening primrose. This may cause decongestion inside the breast, and sometimes we have to do hormonal manipulation with danazol and bromocriptine. Sometimes we have to use anti-estrogen tamoxifen if the female is having severe pain. While the non-cyclical mestalgia, definitely there is no relation of hormones, non-hormonal. It is mainly due to inflammations. Now there can be inflammation of the superficial veins, which we call as Mondus disease, beta. Inflammation of the breast, which we call as mastitis. And behind the breast in the ribs, sometimes there can be inflammation of the second rib, which we call as Tietz disease. So these are various inflammatory conditions which may give rise to pain in this chest area. But pain in the breast would be mastitis or mestalgia. Now for mastitis, beta, as we have been discussing, this would be more common during pregnancy and lactation. What is the bacteria responsible, beta? Staph aureus. And we all can understand, beta, when the baby is taking the feed, then Staph aureus from the baby's mouth. This can travel through the cracks in the nipple of the mother's breast. And once the staph goes inside the mother's breast, there is milk all over the place and the party starts. This party will cause acute inflammation. Signs of acute inflammation, beta: rubor, tumor, Calor, dollar. This is how the patient is going to present to you: redness, swelling of the breast, raised temperature and pain. If the female comes to you at this stage of mastitis, that is before the abscess has occurred, you can simply treat this patient by giving antibiotics and breast support. If by chance the lady does not come to you, right, and if suppose the staph party continues, then it results in breast abscess. Now this breast abscess, early stage, late stage. Early stage, there are small pus pockets inside the breast. The clinical sign of fluctuation, which is seen only when there is good amount of liquid collection present. This stage, beta, this is the stage where not good amount of liquid collection is there. Suppose this is the breast here. In the center, suppose I say that this is the areola here, and this is the nipple in the center. Now what would have happened? There would have been small pus pockets here and there inside the breast. There is not a localized collection of liquid. So the classical sign of fluctuation, what we see in those swellings which have got liquid inside, that will not be present at this stage of breast abscess. So the sign of fluctuation is absent. In these cases, beta, we can do the ultrasound of the breast and we'll come to know that, oh, there are small tiny pockets of pus here and there. So we have to give antibiotics. This AB, what is written here is antibiotics. Plus what we can do, ultrasound guided multiple needle aspirations. Multiple needle aspirations of pus pockets. In the late stage, if the party continues, suppose the lady does not present to us in the early stage of abscess, now what is going to happen? This party may cause localized collection of pus. Good liquid collection of pus may be seen inside the breast. And at this stage, beta, the sign of fluctuation would be present. There was a clinical scenario on 4th of June 2022, and they gave the situation that a lady who is a lactating female is presenting with signs of inflammation along with high-grade fever and all. Ultrasound was done which showed good amount of liquid collection or significant fluid collection inside. Now what should be the treatment in this lady? Obviously beta, when good amount of liquid collection is present, we can make an incision and we can drain this abscess by making an incision. So needless to specify, yes, we will be giving antibiotics, plus we will be doing incision and drainage. Incision and drainage. When we have to drain the breast abscess beta, which type of incision should be given? For this, if we just try to take a look at one image here, suppose I say that there is a localized collection of pus inside the breast. Suppose like this. This is the collection of pus inside. As you can see beta, the arrangement of lactiferous ducts inside the breast is in a radial manner, right? When you have to make an incision on the breast to drain this pus, you have got the option that you can make, suppose, a transverse incision, or you can make a radial type of incision. Now out of these two incisions beta, which incision will cause less injury to the lactiferous duct? The transverse incision or the radial incision? Right? So if you just take a look here beta, just see which out of the two is causing less damage to the lactiferous duct. Obviously you see beta, if you are making a transverse incision, you are cutting more lactiferous ducts, but if you are making a radial incision, you are cutting less lactiferous duct. That is why the best incision to drain the breast abscess is one which causes minimal damage, that is the radial incision. But when you make this radial incision, definitely the lady would be having a scar. And since we know females are quite apprehensive about their breast, so if they don't want the scar over their breast, they may request for some cosmetic incision. For cosmetic purposes, what we can do is, instead of making a radial incision, we can make a periareolar or circumareolar incision. For example, herein what you are seeing is, this is the nipple area. Here, this dark pigmented area, what you're seeing, this is the areola. So what we can do is, we can make an incision at the circumference of the areola. That is a periareolar incision or the circumareolar incision. Now, if you are making this periareolar incision something like this, the scar of this incision, this scar will be camouflaged between the bright portion and the dark portion of the breast. So for cosmetic purpose, we are making a periareolar or circumareolar incision. But overall, beta, to drain the breast abscess, the best incision is going to be a radial incision, right? Radial incision. If we make this incision transverse, then it is going to injure more lactiferous ducts, because the arrangement of lactiferous ducts inside the breast is in a radial manner, right? Okay. Best incision to drain the breast abscess is a radial incision, and cosmetic incision to drain the breast abscess is a periareolar incision. Periareolar or the circumareolar incision. Right. So these were some relevant points related to breast abscess. Since beta on 17th of June, they have given this type of scenario. On 4th of June, there was a scenario from here. On 17th of December, you may expect a scenario from here, right? They may give you that sign of fluctuation is absent. They may give you something like small pus pockets inside the breast. For that, your answer will be multiple needle aspirations of pus pockets, right? Okay. Now let's move into another pathology inside the breast, and that is discharge coming out from the nipple. Again, beta, as we did in the understanding of this mestalgias, let us also try to understand the same thing in these discharges coming out from the nipple. We know that the commonest discharge coming out from the female nipple is milk, but this is physiological. Pathological discharge coming out from the nipple most commonly is serous. Ductectasia, we find green discharges coming out from the nipple. Duct papilloma and cancer inside the breast, blood discharge coming out from the nipple. If we try to understand that why these discharges are coming out, suppose we talk about ductectasia. Now, what actually is ductectasia? For this, if suppose I say that this is the breast, and here in beta we know there are lactiferous ducts, and these lactiferous ducts, they are actually converging at the nipple. What actually this ductectasia means? Ectasia term beta means dilatation. For example, if there is a dilatation in the lactiferous duct somewhat like this, this is what we'll call as ectasia. Ectasia means dilatation, right? A basic understanding what we have from vascular surgery is that whenever there is a traffic jam type of situation, suppose the secretions are moving in this direction towards the nipple, and suppose there is a traffic jam here in this area, then the proximal people are going to get dilated, and there will be stasis of secretions in this area. And this dilatation is what we'll call as ductectasia. The other name of ductectasia is periductal mastitis or plasma cell mastitis. We'll just try to understand this story. First, I'll explain this in Hindi and then I'll explain this in English. Okay? Because there is an important concept here. And this concept you apply in all the 19 subjects. Those who are smokers and alcoholics, जो लोग सिगरेट पीते हैं या अल्कोहल लेते हैं, उनमें पानी की कमी रहती है. अगर उनमें पानी की कमी रहेगी डिहाइड्रेशन रहेगा तो बॉडी के अंदर जितने भी ग्लैंड्स हैं उनके जो सेक्रीशंस हैं उनमें भी पानी की कमी रहेगी और वो सेक्रीशंस गाढ़े रहेंगे। ग्लैंड्स की अगर बात करें बेटा तो चाहे हम ये पैरोटिड या सबमैंडिबुलर या सबलिंगुअल जितने भी ये सलाइवरी ग्लैंड्स हैं इनकी बात कर सकते हैं, यहाँ पे हम ब्रेस्ट की बात कर रहे हैं, पैनक्रियास की बात कर सकते हैं और इस कॉन्सेप्ट को सब जगह लगाने की कोशिश करते हैं। चलिए हम मान लीजिए यहां से शुरू करते हैं सलाइवरी ग्लैंड्स की कहानी से। जो लोग सिगरेट पीते हैं या अल्कोहल लेते हैं, अगर उनमें पानी की कमी हो जाएगी तो उनके जो ग्लैंड्स हैं उनके सेक्रीशंस में पानी कम हो जाएगा, वो सेक्रीशंस गाढ़े हो जाएंगे। जब ये गाढ़े सेक्रीशंस उस ग्लैंड की डक्ट में चलते हैं और डक्ट जहां पे खुलती है वो इलाका थोड़ा सा नैरो होता है, अगर उस डक्ट में सेक्रीशंस गाढ़े हो गए हैं तो जहां पे डक्ट खुल रही है उससे ठीक पहले ये गाढ़े सेक्रीशंस एक ट्रैफिक जैम कर सकते हैं। अगर ट्रैफिक जैम लग गया तो प्रॉक्सिमल डक्ट का पार्ट डायलेट हो जाएगा और ये सेक्रीशंस वहां पे इकट्ठे हो जाएंगे। अगर मान लीजिए हम सलाइवरी ग्लैंड्स की बात करें तो हम जानते हैं कि सब मैंडिबुलर ग्लैंड जो है वो सबसे ज्यादा सलाइवा कंट्रीब्यूट करता है। सब मैंडिबुलर सलाइवरी ग्लैंड ये एंगल ऑफ मैंडिबल के पीछे होता है और इसकी जो डक्ट है सब मैंडिबुलर डक्ट वो यहाँ मुंह के अंदर फ्लोर ऑफ द माउथ में खुलती है और इस डक्ट का एक टॉर्चुअस सा रास्ता होता है, ग्रेविटी के अगेंस्ट होता है। अगर इस सबमैंडिबुलर ग्लैंड की डक्ट में कचरा फंस गया तो प्रॉक्सिमल डक्ट डायलेट हो जाएगी और खासकर जब पेशेंट खाना खाएगा, जब इस सलाइवरी ग्लैंड के सेक्रीशन सबसे ज्यादा होंगे, उस समय जब सेक्रीशंस इस डक्ट में चल रहे होंगे तो रास्ता जाम होने की वजह से ये सेक्रीशंस पेशेंट के मुंह के अंदर नहीं आ पाएंगे। सेक्रीशंस यहीं पे ट्रैप होने लगेंगे, उसकी वजह से सबमैंडिबुलर ग्लैंड की सूजन आने लगती है, पेशेंट को दर्द होने लगता है। खाना खाने से या खाने की खुशबू आने से अगर सबमैंडिबुलर डक्ट में कहीं कचरा फंसा हुआ है तो उसकी वजह से सेक्रीशंस ग्लैंड में ही ट्रैप हो जाते हैं और पेशेंट को एक सूजन और दर्द महसूस होता है एंगल ऑफ मैंडिबल के पीछे। इसको हम बोलते हैं मील टाइम सिंड्रोम। देखिए कितनी अद्भुत बात है। मान लीजिए पेशेंट जो है कहीं पे खाने के लिए गया है, उस समय जैसे पेशेंट ने खाना खाया अगर उसके डक्ट में कचरा फंसा हुआ है तो यहाँ पे अजीब सी एक सूजन आने लगती है और लोग बाग उसको देखने लगते हैं कि ये क्या हुआ। आई रिपीट दिस कॉन्सेप्ट इन इंग्लिश। वी आर टेकिंग द एग्जाम्पल ऑफ सलाइवरी ग्लैंड्स। वी नो there are parotids, submandibular, sublingual glands. In smokers, alcoholics who become dehydrated, they lose water. The secretions of these glands also lose water. So the secretions will become thick. The submandibular gland is the major contributor of saliva, and the duct of submandibular gland opens in the floor of the mouth. It has a tortuous course and it is going against the gravity. If the secretions of the submandibular gland become thick, when these thick secretions are traveling in the duct, the site where the duct is opening, that part is narrow, and these thick secretions will get trapped in the terminal part of the duct. This is going to create a traffic jam situation in the terminal part of duct, because of which the proximal part of the duct will be dilated. Now, if there is a traffic jam situation in the duct, and when the patient takes the meal or maybe the smell of food, this will stimulate the submandibular gland to produce more saliva. More saliva comes into the duct, but there is a traffic jam in the duct, so this saliva will not be able to go into the floor of the mouth. Rather, this saliva will cause swelling of the submandibular gland and pain of the submandibular gland. Swelling and pain at the angle of mandible at the time of meals is what we call as meal time syndrome. The same concept we can apply in the breast. If suppose this lady is a smoker or alcoholic, the secretions of the lobules, they become thick. When these thick secretions are traveling in the duct, as you can see, all the ducts are converging at the nipple. This is the narrow area. So these thick secretions may get trapped in the terminal part of this duct. If these secretions get trapped here, then the proximal part of the duct is going to get dilated, and the secretions will stay in this proximal part of the duct. If we try to apply the same concept in the pancreas, beta, let us just try to understand the story in the pancreas also, because concepts is something what is going to be crucial for our exams. Suppose I say this is the head of the pancreas and this is the body and tail of the pancreas. Here we know is the duodenum. We all know that the pancreatic duct joins with the common bile duct, and then they open into the second part of duodenum at the ampulla of Vater, which is guarded by sphincter of Oddi. We all know, beta, that pancreas would be having the exocrine as well as the endocrine cells. So there will be exocrine, there will be endocrine cells also in the pancreas. Suppose these blue colors are the endocrine. Now what will happen in smokers and alcoholics? Dehydration. Secretions of the pancreas will become thick. Exocrine part, we do understand, beta, that the exocrine cells produce the enzymes. These enzymes, they travel into the pancreatic duct, and then through the pancreatic duct they come into the second part of duodenum where rasgulla is coming or where food is coming. So when the food is coming in this part, the pancreatic enzymes coming here, these enzymes help in digestion of the food. By chance, if the enzymes are not present and the rasgulla is coming here or the food is coming here, no enzymes, then this food will not be digested and this food will pass as such in the stool, malabsorption. If the patient is taking some rasgulla, then this rasgulla, if no enzymes are present here, this rasgulla will pass as such. So rasgulla and rasgulla will be out from the anus, malabsorption, right? Let us try to focus on this dehydration story. Now in smoker and alcoholic, beta, these secretions, when they're traveling in the pancreatic duct, there is a possibility that because these secretions are thick, they may create some partial traffic jam type of situations in the pancreatic duct here and there. Now just look at the screen, beta. If there are partial traffic jam situations in the pancreatic duct because the secretions are thick, now whatever secretions are coming, they are not finding their way out easily. This is adding on to the proximal pressure, the pressure on the proximal cells. The pressure on the proximal cells is increasing. A stage will come when, because of this pressure on the proximal cells, these cells will start undergoing atrophic changes. If the exocrine part of the pancreas undergoes atrophy, it will not be able to produce the pancreatic enzymes. Food will not be digested properly, malabsorption. If this back pressure causes damage to the endocrine cells of the pancreas, endocrine cells in the pancreas, islet cells, alpha, beta and delta cells, majority portion is beta cells. Alpha secrete glucagon, beta secrete insulin and delta secrete somatostatin. If majority is beta and these cells are getting destroyed, then the production of insulin will go down. And if there is insulin deficiency, the blood glucose level will increase, hyperglycemia, diabetes. That is the reason, beta, why people who drink daily for years together, in their pancreas, because of dehydration, there are partial traffic jams at different places in the pancreatic duct. This will add to the proximal pressure, and after years together, this will start causing permanent damage to the cells of the pancreas, not only the exocrine but also the endocrine. If beta cells are destroyed, insulin will not be produced, hyperglycemia, diabetes. Now I understand why people who drink they develop diabetes. जो लोग पीते हैं उनको शुगर की बीमारी क्यों हो जाती है? जो लोग पीते हैं उनको डायबिटीज क्यों हो जाती है? ये कारण है. When these patients come to us in practice and we take the history from these patients, they tell us, Dr. Saab, for the last 20 years, there have not been a single day when I have not taken alcohol. जब डिटेल में इन लोगों से हिस्ट्री ली जाती है तब पता चलता है कि पिछले 20 साल से कोई दिन ऐसा नहीं गया जब इन्होंने पीना हो. That is how this concept of smoking and alcohol is related to different problems inside the body. The story is just related to dehydration. सिर्फ पानी की कमी की हम बात कर रहे हैं, right? Okay, I hope beta you have got this concept nicely inside. Now, let us see what is actually going to happen here. Let us come inside the breast and let us see if there are thick secretions creating a traffic jam here. The proximal duct is going to get dilated, which we call as ductectasia. Since this is a story of dehydration, it is not only going to be a single duct, but this is going to involve multiple ducts, and we'll be seeing ductectasias in multiple ducts inside the breast. Many a times, these secretions, they come out of the nipple, and most commonly it is the green secretions which usually come out of the nipple. Green discharge coming out of the nipple indicates ductectasia, and we go ahead with the treatment of ductectasia straight on. Sometimes because of stasis of secretions, these discharges here may become brownish or may become blackish, or rarely they may even be bloody in nature. So we can find these different type of discharges coming out from the nipple. As we can see beta, these lactiferous ducts are converging at the nipple. Whenever there is any pathology in the duct, this is going to show some manifestation at the nipple. Many times we see nipple retraction. A slit-like nipple retraction is seen in ductectasia, while a circumferential nipple retraction is seen in duct carcinoma. Sometimes what happens beta, when these secretions stay here for a long period of time, we know stasis is an open invitation for the bacterial party, and chronic bacterial party may be seen in this area, which can lead to chronic subareolar abscess, which we call as Zuska's disease. And in these cases, patient can present with a lump beneath the nipple and areola. Depending on how the patient presents to us, we can approach the patient according to that. Let us first see what all is written here, and then we'll see how to approach the different scenarios of green discharge, blood discharge, and lump inside the breast. Right, beta. We'll just try to see this. Most common discharge coming out from the nipple. Overall, beta, this is milk, but this we know. This is something which is physiological. Most common pathological discharge coming out from the nipple is serous. Most common cause of green discharge coming out from the nipple is ductectasia. Most common cause of blood discharge coming out from the nipple is duct papilloma. Or sometimes even duct carcinoma. This is called as plasma cell mastitis. We also call it as periductal mastitis. In your workbook, this is already written, beta. Periductal mastitis. Basically, in ductectasia, there is abnormal dilatation of the lactiferous ducts. ये L जो है बेटा, this is for the lactiferous ducts. Usually, multiple ducts are involved. Commonly seen in smokers and alcoholics because of dehydration. Most commonly, they present with green discharge coming out from the nipple. However, this discharge at times can be brown, black, or even bloody. We find slit-like retraction of nipple in ductectasia, while circumferential retraction of nipple is seen in cancer. Slit-like retraction of nipple is seen in ductectasia, while circumferential retraction of nipple is seen in cases of cancer. Sometimes these patients can present with a chronic subareolar mass or abscess. This chronic subareolar mass or abscess is called as Zuska's disease. क्या बोलते बेटा इसको? Zuska's disease. Right? Now, what should be our clinical approach in management of these patients? Depending on how the patient is coming to us, if the lady is presenting with green discharge, there is no other pathology presenting with green discharge from the nipple, so there is no need to do any investigations. The diagnosis is almost certain, and we just go ahead with the treatment of ductectasia. However, if the lady presents with blood discharge coming out from the nipple, if the lady presents with blood discharge coming out from the nipple, if the lady is presenting with blood discharge coming out from the nipple, look at me, beta, look at me, look in my eyes, look at me, beta. Very important concept. If you find blood coming out from any opening in the body, it should not be taken lightly. Many cancers, they do present with blood coming out from some or the other openings. For example, if you talk about GI malignancies, if you talk about malignancy or cancers in the upper GI tract like stomach or maybe the esophagus, the patient may present with hematomasses. If you talk about lower GI tract like the colon rectum, the commonest presentation of colorectal malignancy is bleeding per rectum. If you talk about urinary tract, urethral opening, the kidney cancer, the urinary bladder cancer, the commonest presentation is painless hematuria. Oh, why there is bleeding in cancers? Because in cancer, what is happening? It is uncontrolled growth of the cells. So the cells are undergoing rapid mitotic divisions. Now, because of these rapid mitotic divisions, it is not only the multiplication of cells, but it is also the growth of the blood vessels what is taking place out there. Now, when blood vessels are also growing in that cancer, definitely, when the cancer cells are growing, there might be breakage of vessels in between, and this will lead to bleeding. That is why many cancers present with blood coming out. Breast cancer can present with blood coming out from the nipple. Uterine cancers, cervical cancers, vaginal bleeding, oral malignancies can present with bleeding from the mouth. Any opening left inside the body. Now, any patient who is presenting with blood discharge, we should have that in mind, especially if that person is elderly. Now, here we are talking about this blood discharge from nipple, February 23, my dear friends, when you will be working in the hospital, and if you see a lady with blood coming out from the nipple, you cannot ignore. The first thing what you have to do in this lady is to rule out cancer. The first investigation what you can do after clinical examination, you collect the discharge, you collect that blood and send to the pathologist, ask him to do a cytological evaluation to say whether cancer cells are present in this or not. If the cancer cells are not present in that blood discharge, we are little safe. Then we do other investigations, like we can do ultrasound for the breast, we can do mammography for the breast. Usually in young females, we are doing ultrasound. In old females, we are doing mammography. Mammography is just a special type of X-ray. Why we are not doing mammography in younger females? It is not that X-ray exposure in a young female will increase the risk of cancer. It is not because of risk of cancer that mammography is not done in young females, but the reason is different. Reason is young females have got dense breast. If the density of the breast is high and we are doing mammography, we can miss the important lesion inside the breast because of huge density inside the breast. If I show you an image in this workbook itself, if suppose I take you for a moment in the end of this workbook, maybe somewhere around 210 or pages, right. This, what you're seeing here, beta, if I just remove myself, this is our old lady. Now, if you look at the mammographic picture in our old lady, right, this is a less density breast. If by chance there is any lesion inside the breast, we can see that lesion nicely in a less dense breast on mammography. But if suppose the density of the breast is more, if the density of the breast is more, then if suppose this is the density of breast, beta, then we might not be able to see the lesion nicely on mammography. So young females have got a high density breast, and there are chances of missing the important lesion inside the breast in a high density on mammography. That means in young females we can miss the lesion, but in elderly females, when the density of the breast is less, then it is very easy for us to find out lesions inside the breast. That's the reason why we don't do mammography in young females and we prefer doing the ultrasound. Right, beta. So we can do this ultrasound mammography. We can do special investigations for the lactiferous duct also. We can put an endoscope into the duct, that is ductoscopy. We can push the contrast into the duct, that is ductography. If by chance the patient is presenting with a lump inside the breast, like we were talking about a subareolar mass, chronic subareolar mass, Zuska's disease, if there is any lump inside the breast, ध्यान से सुनिएगा बेटा, once again be careful. अगर किसी के भी ब्रेस्ट में गठान है तो उसको भी लाइटली नहीं ले सकते हैं. If there is any lump inside the breast, you cannot take it lightly. We have to follow a standard protocol of triple assessment, and this triple assessment comprises of CRP, C for clinical, R for radiological, and P for pathological. That is how we make the diagnosis. Once the diagnosis of ductectasia is made, then we can go ahead with the treatment of ductectasia. So in our clinical approach, beta, if there is a green discharge coming out, no investigations. Just go ahead with the treatment of ductectasia. But if the lady presents with blood coming out from the nipple, the first investigation which has to be done is cytological evaluation. Cytological evaluation of discharge. To rule out cancer cells. Cytological evaluation of discharge to rule out cancer cells. Once the cancer is ruled out, then we go ahead with radiological investigations. We can do ductography, ductoscopy, and if diagnosis of ductectasia is made, then we go ahead with the treatment of that. If the patient presents with a lump, then it is mandatory that we are doing a triple assessment in all breast lumps. It is mandatory that we are doing a triple assessment in all breast lump. Triple assessment. This is CRP, clinical, radiological, and pathological. All breast lumps, this is mandatory. All breast lumps, this is mandatory. So we do a detailed clinical examination where we talk about history and examination. We do radiological assessment. We can do ultrasound for less than 30 to 40 years of age. We can do mammography for more than 30 to 40 years of age. We can do pathological evaluation, like biopsy is the best investigation, and this will give us the diagnosis. Earlier we were focusing more on the FNACs. Once the diagnosis of ductectasia is made, then we go ahead with the treatment of ductectasia. And in the treatment of ductectasia, what we want to achieve, very simple beta. If you just try to focus in this particular area, once again, the problem is traffic jam by the thick secretions. If we can clear this traffic jam, then all the story will pass out and this will become normal. So first what we can do is we can encourage this lady to take plenty of fluids. खूब सारा पानी पीने को बोलते हैं इस महिला को. By giving plenty of fluids, these secretions can become diluted, and then we advise the lady to do breast massage. Now squeezing of the breast, massaging of the breast will express these thick secretions out of the nipple and the traffic jam will be cleared off. Once the traffic jam is cleared, then all these secretions will pass out and this ductectasia story will become normal. You would be surprised to know, beta, that the treatment of choice is conservative. We just encourage these ladies to drink plenty of fluids. and advise just breast massage and the story can settle. However, if by chance these secretions are not going out and the traffic jam persists, then the story is something like when, suppose after dinner we are washing the utensils in the sink, and suppose there is some food remaining in those plates and we are just putting that food in the sink. Sometimes you find that the drainage of the sink has got choked by those food particles. And now all the water which is coming into the sink that starts filling the sink. Right? I would like to repeat this example in Hindi. कई बार हम लोग खाने के बाद अपने बर्तन जब धो रहे होते हैं और मान लीजिए कुछ 2-4 लोगों की प्लेटें और हैं और लोगों ने कुछ खाना छोड़ा हुआ है बाई चांस, और हमने उस खाने को डस्टबिन में नहीं निकाला और उसी सिंक में ही हम उस खाने को निकाल रहे हैं, तो जो सिंक की नाली है वो उस खाने के कचरे से भर जाती है। अगर वो नाली जाम हो गई है, चोक हो गई है खाने से, तो जो भी पानी सिंक में गिर रहा है वो पानी सिंक में भरने लगता है। ऐसे में हम क्या करते हैं? हम कोई झाड़ू की सीख ले सकते हैं और झाड़ू की सीख से उस नाली को खोलने की कोशिश कर सकते हैं। What we do in the management of this situation where the sink is getting flooded with water because of the chokage, because of the drain getting choked, we can just pick up some wire type of thing and we can just try to poke that wire into the drain, and by doing this, that food may go down and the water goes down. This duct ectasia is also something similar story, beta. There is a traffic jam here, because of which the secretions are getting collected. So what you can do is you can pick up some wire or a झाड़ू की सीख, झाड़ू की सीख तो नहीं जाएगी यहाँ पे. You can just pick up a wire and try to put that wire into this lactiferous duct and try to remove these secretions with the help of a wire. If you are able to clear the secretions with the help of a wire, then the traffic jam is cleared off and all these secretions will pass out. Obviously, these are lactiferous ducts, so we have to take the help of microscope to put a wire into these lactiferous ducts. Whenever we are opening something in surgery, we call it as tomy. Here we are opening the duct, so we should call it as ductotomy, but we call it as docotomy. Doco is also duct, and since we are using a microscope, we call it as microdocotomy. Usually this can help us in removing the secretions, but rarely by chance if suppose this microdocotomy is also not helping, then we have to excise these lactiferous ducts. When we have to excise multiple lactiferous ducts, we make a conical incision to excise these multiple ducts, conical incision, and this is called as Hadfield's operation. However, when we have to just remove a single lactiferous duct, then removal of something in surgery is called as ectomy. Removal of the duct, ductectomy or docectomy, help of microscope, microdocectomy. So these are the treatment options what we have in duct ectasia. Let's take a look. The treatment of choice is plenty of fluids, breast massage. That is conservative treatment बेटा. सिर्फ पानी पिलाने से डक्ट एक्टेजिया ठीक हो जाता है. कोई रॉकेट साइंस करने की जरूरत ही नहीं पड़ती. But if by chance suppose this fails, then we can open the lactiferous duct, that is microdocotomy. If this also fails, then we have to do excision of the lactiferous duct. Since in duct ectasia there are multiple lactiferous ducts involved, excision of multiple lactiferous ducts is called as Hadfield's operation. But by chance if on 17th of December the examiner gives the situation that only single lactiferous duct was involved and conservative treatment has failed, microdocotomy has failed, what you are going to do? Now I'm going to excise that single lactiferous duct, and that will be called as microdocectomy. For Hadfield's operation, the type of incision what we are making is a conical incision. while for microdocectomy, we are making a tennis racket type of incision. Tennis racket type of incision. Tennis racket type of incision. So this is how we deal with duct ectasia. This image, what we are seeing, beta, this is a periductal mastitis. These white thing, what you're seeing, these are the fat cells. This narrow structure, what you're seeing, this is the lactiferous duct. And you can see a good amount of inflammatory infiltrate all around the duct. This is what we call as periductal mastitis or plasma cell mastitis in duct ectasias. This image, what you're seeing, beta, this is an image of duct papilloma. Papilloma is a finger-like projection. Can you see some finger-like projections moving here and there in this? Now, sometimes what can happen, beta, if suppose I say that this is the breast and this is the lactiferous duct. Sometimes what can happen, beta, from this lactiferous duct, there may be finger-like projections going out somewhat like this. This is a growth from the lactiferous duct. This is not something kachra phas gaya hai. This is not something clogged secretion. This is a formal growth from the lactiferous duct. Finger-like projections. Papilla. Finger-like papilla. So this is a papilloma. Papilloma. Right? Important. This is a growth. It is not only the growth of the papillary tissue, but also the growth of the blood vessels. So there is a possibility that bleeding may occur, and because of this, we may find this blood coming out from the nipple. So these papillomas can present with blood discharge from the nipple. These papillomas can become cancer. So we cannot ignore them, right? We have to do a cytological evaluation of discharge to rule out malignant cells. If this can become cancer, beta, what should be the treatment for this? क्या पानी पिलाने से papilloma गायब होगा? Will plenty of fluid remove this papilloma? No. Will opening the lactiferous duct remove this papilloma? No. Only treatment should be excision, and we can excise this lactiferous duct. Usually only one duct is involved, so the treatment of choice will be microdocectomy. But if on 17th of December you get a situation that multiple lactiferous ducts are having papillomas, then the answer will be, yes everybody, what will be the answer, beta? Hadfield's operation, right? So that is how we approach these duct papillomas. Duct papilloma is an abnormal papillary growth from the lactiferous duct, usually single duct involved, most commonly present with blood coming out from the nipple. Danger sign, this is pre-malignant. If there is single duct, no atypical cells, the risk of cancer will be less. But if there are multiple ducts with atypia present, then the risk of cancer will be high. Whatever it is, we don't take any chances, and we have to remove the duct, that is microdocectomy, by a tennis racket incision. And if the examiner gives that multiple lactiferous ducts are involved in papilloma, then beta, what we are doing? Very good. Let's have a good big round of applause for you, beta. Hadfield's operation. Hadfield's operation. ये करना है. So this is the story about these duct problems, duct ectasias, duct papillomas, why there is a green discharge, why there is a blood discharge coming out from the nipple. And I think we'll call the session for today here, and tomorrow again we'll be meeting at 9 o'clock or 9:15 9 o'clock probably, but yes, there might be 15 minutes here and there. So till then, have a great evening. Learn all the lessons, whatever we have discussed. Ask as many doubts as possible. Any doubt is a doubt. No doubt is a silly doubt. Please ask as much as possible till the time you are absolutely clear in your mind, right? If I am able to solve your queries, I would be glad and happy, but there might be certain things which you might be thinking even better than me, and I may be discussing with you, and then we'll find a conclusion. What should be the answer for that, right? You are lovely. You are great. You are really dedicated. Just few months better. Keep that positivity inside you. Keep that fire in your belly. Keep studying hard as much as possible. You know that this FMG exam, even if the result, suppose the result is 1%, though this should never happen. Ideally, it should be 100%. Every one of us has the right to pass this exam. Every one of us who is doing so much of efforts, we should be allowed to pass this exam. But even if worst to worst situation, even if the result is 1%, then you all have to be there in that 1%. A person who is scoring 240 or 250 marks, he does not have anything which is unnatural over his body. He would just be doing everyday routine in a slightly different way what others are doing. Whenever he would be studying, he would be focusing more on the intensity of study rather than the duration of study. He would be trying to grab those concepts. That is what we all have to do, and that is what you are trying to do. You are giving your level best. You are working really very, very hard, right? And believe me, beta, if you remain honest to yourself, if you just remain honest to your conscience, nobody will ever be able to defeat you in your life. Just remain honest to your conscience. We don't have to prove to anybody else. We just have to prove to ourselves whether whatever we are doing, is it right or not. If the answer to that question is yes, I am right, then you are absolutely right. If the answer to that question is I am wrong, you are absolutely wrong. So just listen to what your heart says, what your brain says. Never lose that hope. Never ever develop any negative thought inside you. Never ever think that I'll not be able to do. कभी भी बेटा ये बिल्कुल मत सोचिएगा कि मुझसे नहीं होगा. मुझसे ही होगा. मैं ही करूंगा. I am going to do it. देखता हूं किस में ताकत है मुझको रोकने की. मुझे करना क्या है? मुझे इन क्लासेस को अच्छी तरह से सुनना है. मुझे इन क्लासेस को अच्छी तरह से समझना है. मेरे पास ये सारी वर्क बुक्स हैं. मेरे पास हर हफ्ते टेस्ट का मॉड्यूल है. मैं अगर निरंतर इस तरह से मेहनत करता जाऊंगा, हर चीज को अच्छे से समझता जाऊंगा और रोज का काम रोज ही खत्म करूंगा, फिर कैसे नहीं होगा? बिल्कुल होगा. और यही विश्वास, कीप दैट बिलीफ इनसाइड यू. ऑलवेज फील दैट यू आर वन ऑफ द मोस्ट ब्यूटिफुल थिंग what this planet is having. And you have got everything inside you to do wonders, to do miracles. करिश्मे करने वालों के अलग से सीन नहीं होते. People who are doing miracles, they are not having any unnatural things. Everything is natural. They are human beings. You are a human being. You will be doing the miracle. Let's have that fire inside our belly. Keep going, keep going, keep going, and let us see how anybody can come in between our preparation. Thank you very much. God bless you all. Wish you a great evening ahead. And I'll just take a break of 5 minutes, 5 to 8 minutes, and then I'll be solving the queries right here. Thank you very much. Also, I'll be using the speaker mode in the WhatsApp. So if you do not wish to attend this query session, you can just relax, chill out. Bye bye. Take care. God bless. Right, beta. So now let's just have a look at the queries. As usual, first I'll have a look at the batches. So there are no chats in the batches. Let me go into the WhatsApp, beta. Hello. Just a second. Let me just check whether the audio is right or wrong. It's okay. Nitesh बेटा, you want to see the thyroid के complications जो extra लिखवाया था, so you can just have a look once again. The complications of thyroid surgery. Nitesh, you can just have a look at the complications of thyroid surgery right on the screen now. Ragul, good to see your chat. Good evening. I didn't understand. Can you explain thyroid storm? Yes, but a thyroid storm is basically a thyroid crisis. Now, what actually happens is, if suppose the pre-existing levels of T3 and T4 are high in a patient and you are doing a thyroid surgery, during surgery you will be handling the thyroid gland, and when you are handling the thyroid gland, the thyroid hormones will come out into the blood. Already in the blood, if T3, T4 is high, during handling, more T3, T4 comes into the blood. Very high levels of T3 and T4 will lead to severe symptoms of hyperthyroidism immediately. That is what we say thyroid storm or thyrotoxic crisis. And second doubt, after removal, only preformed T3, T4 will be in blood. How it can cause thyrotoxicosis? After removal, it will not cause thyrotoxicosis, but before, okay, you are talking about thyroidectomy. So after removal, what I'm saying, thyroid crisis or thyrotoxic storm is not after removal, it is before removal. It will take some time for removing the thyroid. It might take 1.5 hours to remove the thyroid. And during that 1.5 hours, when you are handling the thyroid gland, dissecting the thyroid gland, at that point the T3, T4 will come into the circulation. In reactionary hemorrhage, what is dislodgement of clot and raised BP? Sometimes what happens, Ragul, when you are doing the surgery, if suppose there is some bleeding, you apply pressure and the bleed stops, sometimes a clot forms there, and that clot puts the pressure on the bleeding vessel, and that is how the bleeding has stopped. Suppose suddenly the patient coughs in the post-operative period, then this clot which was stopping the bleed, clot comes out and the bleed starts. Raised BP, sometimes what happens, Peter, when you're doing the surgery, you are cutting some structure. Suppose you cut the artery and there is significant bleed. You apply direct pressure and the bleeding stops. Probably the artery which was cut by you has gone into a state of spasm. Artery has contracted because there are muscles in the wall of the artery. Now, because of the contraction of the artery, the bleeding has stopped. At the time of operation, you don't see any further bleed. You close the operative site, you shift the patient out, in the recovery, if by chance suddenly the blood pressure of the patient increases, then that artery which went into a state of spasm, suddenly because of high pressure in that artery, the spasm will go off and the artery will start bleeding again. So this is also one of the causes of reactionary hemorrhage. I hope this helps, Ragul. Anindita from Kiev, the periphery of the thyroid gland becomes autonomous without any reason? Yes, without any reason. Sir, when we are saying anti-thyroid drugs given up to evening, presuming the surgery is next morning, that's right. In duct ectasia, aren't we giving antibiotics? Isn't there a bacterial party already? If there is a bacterial party, there would have been an abscess formation. So if there is abscess formation or if there is any evidence of infection, yes, we give the antibiotics. Ravdi from Harbin. Yes, beta. If there is positive pressure outside, then in tension pneumothorax, even if we put wide more needle, more air should be going inside. No, beta. In tension pneumothorax, it is a tension situation. In tension situation, so much of air has gone inside the thorax that now there is more pressure inside the thorax and less outside. Unnati from Orenburg, beta. In pembrolizumab, if we want to do it in India patient, dark or slightly dark, will this? Yeah. We would be able to see some flushing, beta, even in dark skin. Please mention your name and university, and please do send me the screenshot of the workbook questions what you have requested. Invasive means when we are entering inside. Conservative means when we are not doing any operative intervention. Conical incision is neither a radial or transverse incision, beta. It is a conical where the base of the cone is placed at the base of the breast. Prakhar from Usgrowth. You have doubt and fluctuation, how to test it. Prakhar, I am showing it right now on the screen. Basically, if there is any liquid collection, right, somewhere, suppose I say that there is a swelling here, which has got liquid inside. Now, if I try to press this swelling from one side and try to feel on the other side, what will happen? because of fluid inside, when I'm pressing it here, I'll be able to feel that liquid pressure on the other side. Niharika from Orenburg. Yes, Peter, can you please tell me, does Raynaud's occur in males like in some percentage, or it occur only in females? Very rarely it can even occur in males also, Niharika. Abhijit from Davao. In Raynaud's, the arterial spasm is there in cold temperature. So in case the patient was not able to avoid the cold, still gangrene won't be there. If gangrene is developing bitter, that will not be Raynaud's, because in Raynaud's it is just a focal spasm which disappears. That is what is Raynaud's. If the spasm persists, that is not Raynaud's. Yeah, the question number 4, generally in Raynaud's we do not find any gangrene bitter, and in the given image we are seeing the gangrene, so it is not a case of Raynaud's, it is actually a Burgess disease. Thank you so very much, Samrat from Kiev. Thank you, beta. God bless you. May you come out with flying colors. Ali from Karazin, what is microdocectomy and microdocotomy? Please explain once more the difference. Ali, beta, when we are opening something in surgery, we call it as tomy. Like opening the thorax, thoracotomy. Opening the abdomen, laparotomy. Opening the duct, docotomy. When we are taking out something, removing something from the body, like removal of gallbladder, we use the term ectomy. Removal of gallbladder, cholecystectomy. Removal of appendix, appendicectomy. Removal of the duct, docectomy. Akanksha from Jiangxi, beta, can you mention which question you want me to answer? Muhzina from Wuhan, beta, ambulatory venous hypertension. Basically, this is a feature what we see in varicose veins. What is happening in varicose veins, beta? There is more amount of blood which is coming into the superficial veins. Now, that is why these superficial veins are getting abnormally dilated and tortuous, and we are calling them as varicose veins. This is happening because there is a incompetence of the valves like saphenofemoral valve. When the person is walking, muscles are contracting, they are putting more pressure on the deep vein, blood from the deep vein is moving. If there is a saphenofemoral valve incompetence, blood from the femoral vein will come into the great saphenous vein. So at the time of walking, More blood is coming into the great saphenous vein if saphenofemoral valve is incompetent. More pressure in this great saphenous vein on walking. This is called as ambulatory venous hypertension, which is seen in varicose veins. Primary lymphedema is not seen in breast cancer beta. Primary is due to hypoplasia of lymphatic channels. Breast cancer lymphedema, it is secondary lymphedema. Regarding Ollins, I'll send you something. And Pooja, may I know your university beta, please? I've shared the Ollins with you beta. Samriddhi from Bukovinian, please explain late stage mystery again. What should we do rather than radial incision? We are doing incision and drainage, Samriddhi, in late stages of breast abscess. Basically, if formal abscess have formed, then we have to do incision and drainage if there is good amount of liquid pus inside. Radial is the best incision for draining the breast abscess, but if the lady wants to be more cosmetic, she does not want that her scar in the breast should be visible, in those cases we can make a peri-areolar or circumareolar incision. In premenopausal, tamoxifen generally we use 20 mg once a day. Yes, from Orenburg, if we do excision or ablation of great saphenous vein, then can it cause any complication in venous return? No, generally no, because the other veins take up the job and they are sufficient to provide good venous return. Janish from China Medical University, all I have to say to you is that you are a really great teacher. Thank you, beta. Thank you so much. Your hyper spirit really encourages us to get out of our comfort zone and do better. Thanks for the help. Thank you, beta. Thank you for such kind words of appreciation. May God bless you. May God give you all the strength and courage to remain pumped up during this journey. And may you come out with great score and flying colors. Imran from Orenburg, can you please re-explain formation of false aneurysm and can you please differentiate between dissecting and false aneurysm? Yes. Please do have a look on the screen because you have requested diagrammatically. So please have a look on the screen, beta. Suppose this what you are seeing, this is the artery, or I'll draw it here. Now this is the aneurysm. If you look at the different layers of the artery, beta, there is a intima. If the intima is present here, if suppose media is also present here, and if suppose adventitia is also present here, that means all three layers are present in the aneurysm, and this will be called as a true aneurysm. But sometimes what happens, if suppose this is the artery and this is the aneurysm, what is happening if this is the media of the artery and the blood is trying to expand from inside? Then many a times what happens, this flow of blood stretches the muscle of the media, and the media is just stretched and only intima is present in the aneurysm. So if you just focus in this particular area, in this diagram you are having only the intima here, but in this diagram you are having intima, media and the adventitia, all the layers. So that is the difference between true and false aneurysm. Dissecting aneurysm is different, beta. In dissecting aneurysm, what happens? Now, suppose this is the blood vessel, and suppose I say that this is the intimal layer. Outside will be the media. Now, in dissecting aneurysms, what happens? The blood that flows from inside beyond the intima, and now because the blood is flowing here, so what is happening? The blood is getting collected here. Alright? So I hope you are able to understand. If suppose the blood breaches the intima and goes outside the intima but confined within the media adventitia, then this collection of blood, the media would be somewhere here. The adventitia would be somewhere here. This is what we are calling a dissecting aneurysm. Thank you, beta. Thank you very much for the kind words of appreciation. Your query in the case of AV fistula, when we are going to decide with angioembolization, if the patient is having any symptoms, then yes, we are going to treat with angioembolization. Another question, is there any risk that the coil or therapeutic embolus which you are going, you may dislodge or dislocate and cause worsening, doctor? Yes, risk is definitely there, but there are hooks in the embolus what we are using, and we can attach the embolus with the help of hooks to the vessel wall. Yashwant, when there is high BP in angioembolization, there may also to dislocate a coil. If we are attaching with the help of hooks, then usually not. Anish from KNMU, beta, FNAC is fine needle aspiration cytology. We are putting a 23 gauge to 26 gauge needle into any swelling and we are aspirating the cells. RF from Sumi, good evening, very good evening, beta. Why we can't use radiotherapy on squamous cell carcinoma? Generally, the squamous cell carcinomas do not respond nicely to radiation, because the sensitivity of the squamous cell carcinoma cells is not much for radiation. In case of lactating mother after doing Hatfield's, does the breast functions will be completely normal? No, beta. After doing a Hatfield's operation, when you have removed all the lactiferous ducts or majority of lactiferous ducts, the disadvantage of Hatfield's operation is she will not be able to breastfeed the baby. The source of venous thrombi are the calf veins due to prolonged immobilization. Praveen from Osgrowth, thyrotoxicosis seen in nodular goiter. What process that we can see thyroid can basically in nodular goiters, generally there is hypothyroidism only, beta, and in these nodules, usually what we see, the central part of the nodule is having the necrotic follicles, but in the peripheral part of the nodule we may have some active follicles, and sometimes these active follicles at the periphery of the nodule can become overactive and autonomous and start producing more T3 and T4, which can lead to secondary thyrotoxicosis. Shlok from Janelta, you had a doubt about acute spinal injury. What will the manifestation be? Initial spinal trauma? I think, Shlok, let us wait for the orthopedic classes. And also, when we use transesophageal echocardiography, whenever we have to study the motion movements of the valves, and I think the medicine faculty would be a better person to answer when we are going to use this transesophageal echo. Abhiti from Davao, as you said, in Trendelenburg operation after ligation, the great sign is left over below knee. Won't it create any complications, the leftover vein? No, generally not. It gets sclerosed automatically. Firdosh, I hope you have got the Nicoledoni sign, I think in the revision part. Now, another question from you, multinodular goiter, we have high levels of T3 and T4. No, generally not. We do not have high levels of T3 and T4. There are high levels that is seen as a complication rarely in multinodular goiter. That is secondary thyrotoxicosis, which is rarely seen in multinodular goiter. FNAC beta, fine needle aspiration cytology. Please do send me the question specifically which you are wanting to know, beta. The management of Mondas is simply anti-inflammatory. Please do mention your name and university, beta. No, there is no restriction for breastfeeding and mastitis, beta. Nikhil from Orenburg, lump in the breast during radio, what should we prefer in a lady with the age between 30 to 40? Actually, less than 40, the standard guidelines are doing ultrasound. But if there is any high risk present in that lady, then we prefer doing mammography after 30 years of age. Thank you, beta. Thank you so much. Please mention your university also, Hawa. Deva from Trivia, beta. How to differentiate between Raynaud's and Burgess? Beta, the image which you have sent, this is showing gangrene. Gangrene is something we don't see in Raynaud's. Burgess, yes, we can see the gangrene. Thank you very much, Peter, for your kind words of appreciation. May God bless you. Mathili from Takshila American University. Your question is regarding the previous topic we discussed. The full thickness graft is usually taken from post-auricular supraclavicular. Generally, we take only small grafts when we are saying full thickness because we are not able to expand them. Usually, full thickness grafts are rarely used, only to cover the cosmetic areas, Mathili. Your second question is, what if the patient has burns around the same region where the graft is supposed to be taken? It will increase the risk of infection, right, if we create a fresh wound around. So do we avoid graft in these patients, or we use animal skin grafts? We can use animal skin grafts if we do not have the patient's skin intact. The 4 steps in the synthesis of thyroid hormones, beta: T, OBC, trapping, oxidation, binding, coupling. Whatever iodide we take from diet, maybe in the salt, this iodide is trapped by the thyroid follicles, then it is oxidized to iodine, and then iodine binds with tyrosine to form monoiodotyrosine, and then there is coupling of mono plus mono to form di. Di plus mono forms tri, di plus di forms tetra. This is how tri, tetra, T3, T4 are formed. Yeah. Sangeeta from Davao. Beta, the given question, following a road traffic accident, 23-year-old man presents with breathlessness. On examination, he has hypotension, distended neck veins, auscultation, muffled heart sound. This is the Beck's triad, beta. Distended neck veins, that is raised jugular venous pressure, hypotension, muffled heart sound seen in cardiac tamponade. So it should be a cardiogenic shock. Question number 3 and 4 of the workbook from Ajju Vinitsia National Medical University. Now for question number 3, Ajju, there is a traffic jam situation in both the lower limbs. So if both the lower limbs are getting involved in arterial obstruction, that means the obstruction has to be at the level of bifurcation of aorta. That means aorta and a common iliac. So aorto-iliac obstruction will cause ischemic symptoms on both sides of lower limbs. If it is a aorto-iliac obstruction, it is suprainguinal, and for suprainguinal, we use Dacron graft, beta. And for the question number 4, beta, we are seeing gangrene at the tip of the fingers. Gangrene is something which we usually not see in Raynaud's. So this is commonly seen in Burgess disease. Vimal from AMA, dermis involved. There is a question which I am receiving, something related to degree of burn. I don't know from which resources these questions are coming. But if epidermis is involved, it is first degree. Dermis involved, it is second degree. Subcutaneous fat is third degree, and underlying muscle or bone, that is the fourth degree. Now I don't know from where. If this is something somewhere from missed, please do send me that which resource is this. Dhrutiman, about goiter, could you please explain again in brief? And is goiter only occurs in hypothyroidism and hyper too? In hyper also there can be goiter. whenever the commonest cause of goiter is iodine deficiency, whenever iodine is not there, T3, T4 is not getting formed. So T3, T4 levels in the circulation will be low. This will increase the TRH and TSH. High TSH will act on the thyroid follicle, will try to release that preformed T3, T4 from the follicle, but if there is no iodine, no T3, T4 is released. High TSH will stimulate the thyroid follicle to grow. So the follicles will keep on enlarging if the TSH levels are high. Since there is no iodine, despite a high TSH, T3, T4 is not there inside the follicle, so T3, T4 is not increasing in the circulation. T3, T4 remains low, TRH, TSH remains high, and TSH keeps on enlarging the follicles, resulting in goiter. Uh, Ashik from Irkutsk, please do avoid such references. This is the suggestion which I can give to you. Ayan from Orenburg, one question given in workbook that blackish is caused by Burgess. Yes, I think you have listened to this explanation, I hope. Gangrene is something which is not a feature of Raynaud's, because in Raynaud's there is just a spasm of the arterioles, not a occlusion of the arterioles. Pragyan, may I know your university, beta? Yes, if there is hypothyroidism, there is a possibility that if hypothalamus is secreting TRH, which is acting on the anterior pituitary, which is forming the TSH, there might be irritation, and continuous insult to the pituitary may lead to high prolactin levels. Mohammed from Kiev, beta, this is tablet of oil of evening prime rose. This is for decongestion used in cyclical mastalgias. Lerick syndrome, beta, please do mention your name and university. Lerick syndrome is something where the patient presents with pain in the buttocks and the thighs associated with impotence. If both the first lumbar ganglia are removed in lumbar sympathectomy, we can find this Lerick syndrome. Yeah, polymazia and polythelia are abnormal condition, beta. Generally, a female is having two breasts and two nipples, but if there are multiple breasts and multiple nipples, that is abnormal. Harini from Davao. I hope I just explained the question number 3 and 4. I'll send the audio explanation right away. Yes, usually it does not cause any problems if we ablate the great saphenous vein. The other veins take up the job and the venous return is normal. Devika, I just explained the fluctuation wherein if there is a swelling who has got liquid collection inside, and if you try to press from one side and feel from the other side, you can feel the liquid pressure and you feel that the fluctuation is there. Jitin from Perpetual Beta, poi kilo, thermia. Thermia is temperature, poi kilo is cold. So coldness is what is poikilothermia. Please do mention your name and university, beta. This is a wrong answer which is given at so many places because they have been using Parkland earlier, and this is an old question and they have solved it by the old way, but that is not the correct way. The answer now is according to ATLS, beta. Basic Firdosh, in this question number 11, he is asking Homan's sign is seen in. So the answer should be DVT. Now DVT is seen in prolonged immobilization situations. And Firdosh, regarding the other question, if there is a ischemic symptom signs in both the lower limbs, the obstruction has to be at the bifurcation of aorta, that is aortoiliac, which is suprainguinal, where we use the Dacron graft. For this first question, beta, the trunk in a baby 6-year-old, this should be somewhere around 30-32%. And then what else? And whole head and neck, you can just imagine that at 6 years of age, it should be 13 somewhere. So we can just add that 32 with 13. So it should be somewhere around 45%. In the second question, there is head and neck burns, buttocks burnt, and thigh burns. So head and neck child, the age is not mentioned. So this can be anything between say 9% to 18%. Then buttocks would be somewhere around 5%, and the thighs would be somewhere around you can consider 20%. So 20 plus 5, that is 25, and head and neck can be anything between 9 to 18. So let us take it somewhere around 12. So 25 plus 12, that would be somewhere around 37. Yeah, we can give antibiotics to prevent this Staph aureus infection. Beta, please do mention your name and university. I got it, beta. You are the Mahi from Our Lady of Fatima. Thank you very much. Varsha from UV Gulas beta. Escarotme in skin grafts, not in skin graft beta. Escarotme is for eschar. Eschar is somewhat we see in deep burns. So if the skin becomes thick and leathery and it is not allowing the movement of the underlying things, or if it is pressing on the underlying vessels, we just make a longitudinal incision in that eschar that is in the skin which is burnt to release the pressure on the underlying structures. Thank you very much, Peter, for your kind words of appreciation. Your second doubt, after stripping the great saphenous vein, what is usually done to the vein? What about the blood that is usually carried by GSV? The vein is discarded, beta, and the venous drainage will be by alternative channels in the lower limb. Agnes from Perpetual beta, thoracic outlet syndrome. I just gave the example of cervical rib beta. If there is extra rib present, then this may put pressure on the mediastinal structures like the major vessels are passing here. It may put pressure on the subclavian arteries, which may decrease the supply to the respective upper limb. Shubpreet from Kharkiv in Pringles says we ligate the hepatic artery, but for how long? We are not ligating beta, we are just pressing that. We are not ligating, we are just pressing that so that the liver blood flow is gone, and then we gradually release that pressure so that we see from where the bleeding is taking place and we can take direct control of the bleeding. Jaydeep from UV Gulas beta, if we remove the GSV, will there be no? There is no problem beta, the other veins will take over. Pragyan from Armenia beta, in hypothyroidism both levothyroxine is given in question, then what do we answer? Iodine would be the best answer beta. Nandini from Our Lady of Fatima, thank you beta, thank you for your nice words of appreciation. May God bless you and may you come out with flying colors beta. Ashik from Irkutsk. I have a small concern. Why can't we have the surgery classes after another? Because that would make surgery to understand way faster and better. Please let me know, Ashik, which part in the anatomy related to surgery you're not able to get it, because anatomy classes are scheduled in the middle of August for you. Aditya, please do mention all your surgery related doubts to me on WhatsApp here at my number. I repeat, beta, epidermis is first degree, dermis is second degree, subcutaneous fat is third degree, and muscle or bone is fourth degree. So please follow this, beta, and change the answer wherever you feel there is a different answer given. And please do mention your name and university, beta. Thank you very much for your patience, beta. May God bless you. Wish you all the best. Have a great night. Bye bye.